Cells coverage for SCD Summit. We're excited to have you here for our annual conference, and we thank everyone for being patient. Normally, we have this meeting in August, but this year we had it in December, right before the holidays. So today we'll be hearing from a dynamic group of individuals. We'll be hearing from CMMI themselves, and we'll also be hearing from community members as well as Medicaid directors and commercial payers. The goal of today is to really get a snapshot of what coverage and access looks like for the sickle cell disease community, but it's to also make sure that we're including every voice that's involved in healthcare, both recipients, people that administer healthcare and coverage, as well as those that are taking care of individuals with sickle cell disease. So if you could just wait and be patient a little bit while we work on pulling up slides. Thank you. Next slide. Slide. Great. So my name is Ashley Valentine. I'm president and co-founder of sickle. sickle is a national advocacy organization co-founded by myself and my late brother, Marcus Valentine. And the mission of sickle is to elevate the voices of the sickle cell disease community and share their stories of resilience. And the goal here is to make sure that the community voice is brought into every decision that is being made for the community. And today is an example of this. So sickle cell has shaped our entire lives, as my brother said, but it has always felt like normal to our family. And because of that, this is why we highlight the stories of resilience. Next slide. Great. So on today's agenda in the morning session, you'll be hearing from our keynote speaker today and learning about the landscape overview of treatments and access for the future, as well as a panel discussion talking about the community perspective and reflections on the progress of sickle cell disease. The afternoon session will really be focuses on the CGT access model, so the cell and gene therapy access model, and learning how a lot of our advocacy works are influencing systems. And we'll be hearing finally from the sickle cell community for them discussing how their work covers some of the gaps, the coverage gaps when they administer wraparound services. So without further ado, I'd like to introduce our keynote speaker. So Aurelia Chaudhary is the lead modeler for CMMI CGT Access Model. And the goal of this keynote presentation is to discuss the uniqueness of the CGT Access Model, touch on how the model aims to ensure equitable access to CGT for sickle cell disease, and provide us with details about what happens next year as it relates to access. Aurelia Chaudhary is the model co-lead for the CGT Innovation Center at CMS. She's graduated from Rice University with a degree in economics in 2009. She worked in healthcare consulting and for the Massachusetts Medicaid program prior to attending Yale Law School, from which she graduated in 2016. Aurelia spent several years in litigation, clerking for 2 federal judges, and later working for plaintiff side antitrust firms. Aurelia joined CMMI in 2021. Prior to taking her current role, she served as the model lead of the value-based insurance design model. So without further ado, Aurelia, I will turn it over to you.
I'm so excited. Can everyone hear me? Great. I'm so excited to be here today and so delighted to be able to give everyone here an update on the cell and gene therapy access model. Next slide, please. So what is the cell and gene therapy access model? You all may recall that back in, October of 2022, October of 2022, a little more than 2 years ago, we received the executive order on lowering prescription drug costs for Americans, which called on the Secretary of Health and Human Services, and in particular, the Centers for Medicare and Medicaid Services, to develop a report on what kinds of models we might be able to test that would make prescription drugs more affordable and accessible for Americans. And the high-level concept we developed in that report was a focus on what we call outcomes-based agreements, that is, OBAs, agreements that tie payment to the manufacturer at the end of the day in some way to the actual impact that a therapy has on the patients that take it. And the idea was that maybe we could leverage this framework of outcomes-based agreements to achieve the goals stated here: improving beneficiary access to transformative therapies, reducing healthcare utilization and expenditures, and improving healthcare outcomes for our beneficiaries. Next slide, please. The overall framework for the model. I'm so sorry, the slides are being projected in a way where the coloring is slightly off. They're still readable, but if it might be fixable, that could be nice. But I'll just keep going. The structure of the model is that CMS would negotiate the key terms of an outcomes-based agreement with manufacturers of cell and gene therapies on behalf of state Medicaid agencies. And state Medicaid agencies would then have the opportunity to decide whether or not to participate in the model. This would all take place in a few stages. First, that CMS negotiation with manufacturers. That negotiation would include CMS tying manufacturer payments to specific outcomes. CMS would offer optional funding to states through a notice of funding opportunity to states that choose to participate in the model. And finally, CMS would support states in operationalizing the model. One of the things that we learned over the course of doing outreach with interested parties from a variety of sectors is that while states, manufacturers, and others see outcomes-based agreements as a potential avenue for improving access and lowering costs, states have found it difficult to operationalize these, both because they're difficult to negotiate and because it can be difficult to actually track what's happening over the long run with patients. So the vision here is for CMS to support states both upfront in negotiating these arrangements and at the back end in implementing them and evaluating them. Next slide, please. The model takes place across three key relationships, right, between the three sort of central parties involved here, CMS, the manufacturers, and the states. Between CMS and the manufacturers, as I mentioned, CMS negotiates the key terms of a deal, an outcomes-based agreement, which manufacturers then make available to states, and manufacturers submit certain data to CMS. Between CMS and the states, states submit data to CMS to support CMS's role in administering these outcomes-based agreements. States agree to meet certain requirements to participate in the model, in particular requirements with respect to access, which I'll get into in some more detail here. And states and manufacturers implement between them an outcomes-based agreement, which includes both terms related to pricing and also terms related to coverage and other things states have to do to ensure access for beneficiaries. Next slide, please. So where are we now? As I mentioned, we began with the executive order, which included, which called on us to do a high-level model design. In January of this year, we announced that the model was going to be developed with a focus on gene therapies for sickle cell disease as our primary area of focus. And over the past year and a half, 2 years, we have been engaging with interested parties, Sickle being key among them. And I'm so grateful for Sickle, Ashley, this organization, and all of the sickle cell community groups that we have been able to be fortunate to engage with over the past couple of years as we develop this model. The input that we've received has meaningfully shaped policy, whether it's in understanding the access barriers that Medicaid beneficiaries are likely to face, identifying ways that manufacturers can address those access barriers, for example, through fertility preservation supports, identifying policies that states need to enact in order to support access, or identifying the role that community-based organizations might play in helping our beneficiaries access these potentially transformative therapies. Over the past several months, we were engaged in manufacturer negotiations, which were again really informed by what we heard from interested parties, including patients, about the things that would matter to them in a negotiated outcome. We are now at the stage of being able to announce that we successfully reached negotiated agreements with both manufacturers of gene therapies for sickle cell disease, Vertex Pharmaceuticals and Bluebird Bio, and we are now excited to be turning to the next phase of soliciting state applications to participate in the model. The state application period runs from December 2024 to February 2025. And so the next few months for us are really going to be an all-out sprint in talking to states about the model, letting them know the key terms that we've negotiated with manufacturers, explaining to them the requirements for participation, providing technical assistance to states as they navigate the decisions of how, when, and with what policies they might potentially enter the model, such that we can facilitate states entering the model and launching as early as January 2025, but potentially as late as January 2026. Next slide, please. So what I wanted to mostly spend my time today focusing on are the parts of the model that I think would be really important to beneficiaries, which include a few things. They include what are the operational requirements that we have of states in order to ensure that beneficiaries can meaningfully access these therapies? What are the supports and services that manufacturers will be bringing to the table as part of this model's comprehensive effort to improve access to these transformative therapies? And what is CMS doing through the notice of funding opportunity, the optional funding available to states, and how can community-based organizations and patient voices play a role in that process? So I'll move on through these, but I'm going somewhat quickly so that we make sure that we have plenty of time for questions at the end. So please feel free to put questions in chat, or I think they'll be moderated as I finish my presentation. So really quickly, what is it that states are operationally required to do in order to participate in the model? Well, there are certain legal requirements, right? They have to apply for a state plan amendment that allows them to engage in these kinds of outcomes-based agreements. They have to have a standardized access policy. So under the key terms that we've negotiated with each of the manufacturers for gene therapies for sickle cell disease, we have agreed with them on what the coverage policy the state needs to have. That is, what is the criteria that a state is going to use to decide who's going to qualify for coverage of gene therapies for sickle cell disease or not. And any state that's participating in the model has to adopt its access policy and has to make it available so that everyone can understand what this policy is, so that both the patient and their providers can easily understand what's the documentation that they need to submit to a state in order to demonstrate that this is a patient who should qualify for coverage of gene therapies for sickle cell disease. Another important requirement for states to participate in the model is what we call a carve-out of the model drug from the inpatient bundle. So this is maybe getting a little bit in the weeds, but it's important to be aware that many state Medicaid agencies reimburse hospital stays on what we call a bundled payment basis. So a hospital gets a lump sum of money that covers all of the services and drugs provided to a patient during the course of their stay. This bundled payment framework is not a great fit for drugs like the gene therapies for sickle cell disease, which are substantially more expensive than what a hospital would receive for a regular inpatient stay. So a state participating in the model is required to separately reimburse for gene therapies for sickle cell disease through a separate payment that pays the hospital at the price that the hospital paid for the gene therapy, such that hospitals are essentially held harmless for the cost of these drugs. This is a really important aspect of the model, even though it's somewhat, it seems like it might be somewhat inside baseball, because if hospitals don't have assurance that they're actually going to be paid at the price that they paid for the drug, they may not have the ability to financially outlay the costs necessary to make sure that they actually are able to administer the drug to the set of patients that could really benefit from it. And I know that there are a bunch of folks from state Medicaid agencies who are on the line as well. We are happy to discuss all of the complexities behind the carve-out and separate reimbursement in more detail at our state webinar tomorrow, or feel free to reach out individually to the model team. We are in close contact with our colleagues at the CMCS Division of Pharmacy in figuring out how to operationalize this and provide technical assistance to states as they sort through this. There are provider reimbursement requirements as well. So providers will have to participate in the patient registry that CMS has partnered with in order to track long-term outcomes for patients undergoing gene therapy for sickle cell disease. We're partnering with the Center for International Blood and Marrow Transplant Research, which is, an existing patient registry with a long track record of long-term follow-up with respect to patients who go through allogeneic transplant for sickle cell disease or donor-based transplants. Currently, we understand that every treatment center that is delivering gene therapies for sickle cell disease already participates in this registry, and we look forward to continuing to build on those connections as additional providers come on board. States are required to follow certain financial accounting rules to make sure that they are not claiming services that are paid by manufacturers. And finally, states have to align with their managed care entities. Something like 70% of Medicaid beneficiaries are covered by a managed care entity that contracts with their state to support the state in providing coverage for services. And one of the requirements of the model is that states, at the end of the day, by January 2026, have to participate with respect to both their fee-for-service lives and their managed care lives, which means that whether a beneficiary is covered by the fee-for-service part of their state Medicaid program or the managed care part of their state Medicaid program, they benefit from the coverage policy, the outcomes-based agreement, the rebates, the access provisions similarly. Next slide, please. Another important aspect of the model that's going to be required of states who participate in the model is what we call provider network adequacy. So states who participate in the model are going to have to ensure that beneficiaries can actually access the gene therapy. And this may be a challenge for some states because there may be states for whom there is no hospital inside the state that offers this therapy, because so far there are a limited number of sites that offer these complex therapies. So a state applying to participate in the model has to attest that beneficiaries will have access to at least one provider in or outside the state, and they'll have to maintain a contract with at least one treatment center that can administer the gene therapy, whether that's inside or outside of the state. As I mentioned, the state will have to publish the coverage criteria that they'll be applying to to the gene therapies for sickle cell disease in a manner that can be accessed by providers. And if necessary, they will submit to CMS a template for what we call a single case agreement, which is sort of a special agreement that a state might have with an out-of-state hospital to ensure that there's that agreement up and running, so that as a patient comes in requesting coverage for a gene therapy for sickle cell disease that might be provided at, say, an out-of-state hospital, there's a sort of path laid for that to happen, which might avoid potentially months of delay in negotiation, as we have sometimes seen can potentially happen as complex care for patients who have to travel out of state can sometimes create delays. Finally, states have to identify primary and secondary points of contact for providers with respect to negotiating single case agreements, going through the prior authorization pathway, enrolling providers as required. And this is all based on feedback that we've heard from patient groups, from clinicians, and from states to identify ways that we might potentially proactively address circumstances that might end up creating delays or challenges for beneficiaries as they move through the process of these complex care journeys, like the journey for gene therapies for sickle cell disease. Next slide, please. States participating in the model also have to attest that the state is going to ensure timely access to non-emergency medical transportation services, which, again, given the long distance that some patients may have to travel in order to go to, for example, an out-of-state treatment center or even an in-state treatment center that may be very far away. You have to ensure the state has to attest that these will be provided and describe how they're going to communicate these services, the availability of these services to beneficiaries. One of the important things that we realized in the course of doing our beneficiary outreach over the last couple of years has been that there's not always great communication that's flowing between the patient community and the states about exactly what is covered by the state and how beneficiaries can access those covered services. So we look forward to working from states to ensure that that communication circle is met. And working with patient organizations like Sickle has been a really important part for us of making sure that we're able to disseminate what are even the existing statutory requirements on states and being able to make sure that that communication loop gets closed. Next slide, please. As I mentioned at the top, another important set of supports for states is going to be coming in through the notice of funding opportunity, which I mentioned is an optional part of the model. So every state applying to participate in the model has to go through the state request for application process. It has to meet the requirements that I talked about earlier, which will apply to all states participating in the model. An optional aspect of the model is the notice of funding opportunity, where if a state so chooses, it can request funding from the federal government to support its implementation of the model. That's a separate application process. States may choose not to go through, but we are excited to see what states apply for and which states will choose to participate with respect to that aspect of the model. And now I'll go into a little bit more detail about what that can offer for states. Next slide, please. The notice of funding opportunity allows states to request funding under a cooperative agreement that supports two kinds of things. The first is implementation funding for model activities. That's things like staff time to coordinate with managed care organizations to ensure that they're aligned on the common coverage policy that's going to apply across fee-for-service and MCO lives, or staff time to deal with out-of-state providers, to negotiate those single case agreements or establish a contract as required. It can also apply to milestone funding for states who choose to embark on research projects. States may choose to test, for example, research projects around supporting community-based organizations in delivering certain kinds of peer supports and services, or any number of other things. We look forward to states being creative about what those research projects might be in terms of testing potential interventions that might improve beneficiary access to transformative therapy. Next slide, please. For implementation funding, states can request both funding for activities that are associated with mandatory aspects of the model, as well as optional model activities. Optional model activities are things that might increase access to gene therapy or promote multidisciplinary comprehensive care for beneficiaries of SCD who are going through or considering going through gene therapy. Another important aspect that we've learned over the past couple of years of outreach with clinicians, patients, and states has been that beneficiaries require a broad range of potentially different kinds of supports and services over the course of their gene therapy journey, whether that's thinking about behavioral health supports, peer supports, caregiver supports along the way. Comprehensive care for these beneficiaries will require a multidisciplinary approach, and we look forward to supporting states in the variety of approaches they may take in ensuring that that happens. Next slide, please. Some additional detail as to the optional model activities, and I'm going into this because states will be permitted to partner with community-based organizations in engaging in some of the optional model activities under the Notice of Funding Opportunity. And we imagine that with respect to many of these things, building awareness, ensuring access to behavioral health services, ensuring that health-related social needs like housing, nutrition, and childcare are addressed, providing patient navigation services, providing family planning services. All of these things may be aspects of the model in which states may choose to partner with community-based organizations. There are a number of ways that states can choose to take advantage of the Notice of Funding Opportunity. Community-based organizations are one of them. States can also choose to expand Medicaid benefits, potentially using the optional sickle cell disease benefit. States can also conduct direct outreach campaigns directly to beneficiaries. States can partner with providers of gene therapy or sickle cell centers in ensuring that their optional model activities are having the impact on access that they would hope. But these are all really a menu of options for states to choose from. So as we interface with community-based organizations, with patient groups over the next couple of months, we encourage you to reach out to the state that you're based in, reach out to your state Medicaid agency, talk to them about the Notice of Funding Opportunity, read through it yourself, see if there's anything in there that you think this is something that we as a patient group or we as a community-based organization want to help the state in. We want the state to ask for funding to support us to do part of this. We look forward to you all building relationships with your state Medicaid agency and potentially the model being a vehicle for those relationships to be created. Next slide, please. As I mentioned, partnerships with CBOs can play a lot of different roles, increasing awareness, increasing access to support for ancillary services. I want to mention childcare supports here specifically. One of the things we know about the gene therapies for sickle cell disease is that the patient population who may be going through this journey includes a fair amount of children or young adults who may themselves have young children, and the availability of funding in the Notice of Funding Opportunity to support community-based organizations in addressing childcare supports and other caregiving supports is something that we're really excited to be able to have included there, and we really hope that some states and community-based organizations are able to take advantage of. There are a range of other opportunities for community-based organizations to be involved through NOFO funding in addressing health-related social needs and in providing community health worker or patient navigation supports and peer supports. Next slide, please. So I know that I'm at the end of my presentation time, and I already see some questions coming in the chat. I encourage everyone to go to our model website, which has additional model resources. And if you guys have further questions that we don't get a chance to answer today, I encourage you to reach out via email to cgtmodel@cms.hhs.gov. I check that email every day. We get outreach from states many times a day. We are very excited about the level of state engagement we've had so far, but we are also available to talk to patient groups and community organizations who have interests or questions about the model. Thank you. Selena, should I just directly answer questions from the chat, or Ashley?
Hi, thank you. Yep, I can ask the questions. Thank you so much for that presentation, Aurelia. I learned a lot even here in the audience, and I think it's really important, and we're happy to see that your team has really thought about how to ensure that these wraparound services are covered, because that's really an equitable way to ensure that the community can undergo a gene therapy. So to get us started here on questions, the first one is, does this model apply to Medicare under the traditional Part A, B, and D, and under Advantage Plans Part C?
That's a great question. So I may not have been as clear about this as I should have been. This is a Medicaid model for non-dually eligible Medicaid beneficiaries. So if you are a Medicare beneficiary, this model is unfortunately not about you. We are focused on Medicaid beneficiaries only.
Great, thank you. And I do want to remind the audience, if you could put your questions or comments in the Q&A section, not the chat, then that will be helpful for us. So the next question here is, why would a state not opt to apply for state carved out financial assistance to cover SCD gene therapy?
So to be clear, the model is not financial assistance for states to cover the cost of gene therapy. What the model provides is access to a set of CMS negotiated key terms that a state can then implement by means of its own agreement with the manufacturer. So we provide support in having negotiated those key terms, but it's not direct financial assistance for the cost of gene therapy. The carve-out is not itself financial assistance either. The carve-out is really a separate way of paying for hospitals to ensure that hospitals are not losing money on providing these gene therapies to patients. And states face a range of challenges, financial, operational, in implementing the carve-out, and we are excited to help states in thinking through those challenges and providing technical assistance to states moving forward.
Wonderful. Here's another question. Will there be any publicly accessed resources regarding which states opt to join and or have stage funded carved out?
So per the model timeline that we have posted on our website, this summer we'll be announcing a final list of states that have opted to participate in the model. By this summer, we should sort of have a full list of all the states that are participating and when exactly they will be going live in the model. But there may be states or manufacturers may choose to share interim updates before then.
Wonderful. And so we have a few more questions. For small clinics that cannot afford the cost of the drug up front, can they purchase the drug through a specialty pharmacy?
So the gene therapies for sickle cell disease are not going to be administered in small clinics. To be clear, the gene therapies for sickle cell disease are really administered in a patient journey that looks a lot like a bone marrow transplant, right? And so they will only be administered at the authorized treatment centers or qualified treatment centers that have partnered with the manufacturers. And there are 60, 70 of those around the country. And they're, for the most part, children's hospitals or large academic medical centers. And so it's not really a small clinic kind of product. That said, we anticipate that these academic medical centers, these children's hospitals, will be partnering with smaller clinics that provide services to patients with sickle cell disease because those clinics will be referring patients into the therapies, the treatment centers that offer the gene therapies. But the small clinics would not be in the position of actually like purchasing the drug, for example.
Great, thank you. For CBOs, how do we make sure that the state considers us as a partner? Many of us are already sharing education on gene therapy and other resources.
That's a great question. I think Ashley and Sickcells have done such a wonderful job of building relationships in the federal government and with state governments. If you as a CBO are not in touch with your state Medicaid agency, reach out to Ashley, reach out to us. We know who these people are. We can help you make introductions. And we can help put you in touch with the people at your state who might be thinking about the model if that's something that they and you would like to happen.
Fantastic. I was going to say the same thing. Great. We have a few more questions. You're popular, Aurelia. The questions are rolling in. So we have about 5 more minutes. So if anyone has questions, feel free to drop them in the Q&A. So we have a comment here from one of the manufacturers. It says one of the manufacturers does provide options to qualified treatment centers to procure gene therapy, both via specialty pharmacies and specialty distributors. So that is a comment to one of the questions. And so here is a few more questions. When will the information on funding be out for states to partner with community?
So the notice of funding opportunity is published, available on our website. If you go to our website, any state can take a look, or any community-based organization can take a look at the grant opportunity. So that information is already available. States have until February 28th to apply for the notice of funding opportunity, and decisions about the notice of funding opportunity will be made by the end of June.
Wonderful. So here is a question. Since both manufacturers have signed the agreement, then the states that participate in the model will cover both products, correct?
No. So states have the option of participating with respect to one manufacturer or the other, or both, depending on the state's preference. So the manufacturers have to make the CMS negotiated terms available to all states, and states can choose to say yes to one or both of the manufacturers. We have worked very hard through the negotiation process to offer a set of terms for both manufacturers that we think states will find attractive and operationally feasible. And so we hope that states will participate with respect to both manufacturers because we think that's best for access and for patient choice. But states are not required to do so. There are also going to be some unique dynamics here. For example, there are some states that have multiple treatment centers for one manufacturer and none with respect to the other. So they don't really envision having a lot of volume go from one manufacturer or the other. There are just going to be different individual state-by-state dynamics that play out over this process. If you are a community-based organization or a patient group and you have specific thoughts about coverage of one or both products, we encourage you to reach out to your state Medicaid agency and talk to them about it.
Fantastic. So here's a question. What is the long-term vision for the access model in ensuring sustainable and equitable access to cell and gene therapies for sickle cell disease? And how might it influence the future of healthcare policies?
Wow, well, that's a doozy. So I'll say this is really a toe in the water for us. We are very excited that the first condition for us to focus on is gene therapies for sickle cell disease. These are potentially transformative therapies that can make a huge difference to a community that has historically been underserved by us, the federal government, and can meaningfully, I think the model is something that can meaningfully address some of the access barriers that inequitably exist with respect to patients with sickle cell disease. But we have never done anything like this before, and we have a lot to learn. We have learned a lot over the last 2 years. As I mentioned, Ashley, sickle, the patient community for sickle cell disease has been an important part of that learning. The manufacturers, the states have also been an important part of that learning. And we're going to continue to learn over the next year as we figure out how can we get states to apply and participate in the model? What are going to be the roadblocks to states participating in the model? What kind of challenges do we have to address? What kind of operational and technical issues do we have to resolve? And I think as we go through that learning process over the next year of actually starting this model up, we're going to have a tremendous amount of expertise that we can then bring to bear to better answer this question of what does the long-term future of the model look like. I think it's very early to say, although we have encouraging progress so far and high hopes. I hope that's enough of an answer for you, Ashley.
That was a fantastic answer. And so, Aurelia, we are out of time. I just want to say thank you so much for participating with us and explaining the model and also being willing to answer our questions. If you are in the chat, please give Aurelia a round of applause. And with that, we will transition to our next panel. Thank you so much. Wonderful. So this next panel is to hear from the community perspective on how the landscape for sickle cell disease has changed since 2014. And 2014 is a date that we use because that was the first ever and currently the only FDA patient-focused drug development meeting. It's been 10 years since that historic meeting. And since then, we've seen monumental shifts in awareness about sickle cell disease, an increase in community advocacy surrounding access and care, an uptick in federal funding and federal engagement, and a lush pipeline for innovative treatments. We want to speak with Tristan Lee and Pat Corley about their reflections on the past decade for sickle cell disease. Pat Corley is a compassionate health educator and a nurse navigator. In 1979, Pat became the nurse coordinator for one of 10 newly found National Institutes of Health sickle cell centers. She was a nurse coordinator at LAC and USC for the Sickle Cell Disease Comprehensive Center for over 3 decades. Her many projects have included the Unveil Sickle Cell Campaign, sitting on the NIH Focus Groups Committees, the International Association of Sickle Cell Nurses and Professional Associates Committee, and the Children's Hospital of Los Angeles Group Committee. Today, Pat is the recipient of the Elliot Vichensky Healthcare Provider Award. She lectures at numerous institutions and partners with Kayan Wellness Center and Access Advocacy to improve the plight of persons living with sickle cell disease. Now, we're also going to hear from Tristan Lee, who's a Sick Cells ambassador. He's a Sick Cells Advisory Board member, as well as an ambassador and a community member. And Tristan was diagnosed at age 6 months with sickle cell disease in 1983. Due to not much being known about sickle cell disease, the doctor who diagnosed Tristan told his mother and grandmother that he wouldn't live past the age of 20. However, being a family of faith, they trusted in the Lord, understanding that God has the final say. Tristan is 41 years old today. Today, Tristan is a professional model, an actor, and has a fashion line for sickle cell disease called Devo Stars. He's a professional advocate for SCDAA and sick cells, and he's had the opportunity of being NORD's Rare Disease Day Hero in 2020, presenting on the inaugural HHS Sickle Cell Disease Summit during 2024, and representing the sickle cell disease community locally, nationally, and internationally. Spreading sickle cell disease awareness is a passion for Tristan just as much as fashion and acting. So with no further ado, we would like to welcome Pat Corley and Tristan Lee. Hi, Pat. Hi, Tristan. How are you today?
Hello,
Wonderful.
Ashley.
How are
We are
you?
doing good.
Great. I'm so happy to see you both here. So why don't we get started? Tristan, can you tell us about yourself and your connection to sickle cell disease?
Of course. So my name is Tristan Lee. I am a sickle cell warrior with sickle cell type SS. I am 41 years old from Williamsport, Pennsylvania. I was diagnosed with sickle cell disease at the age of 6 months. Doctors said I wouldn't live to be past 20. And like I said, by the grace of God, I am here today living well with sickle cell at 41. I am a patient advocate for, of course, the fabulous Six Cells, SCDA, tons of other sickle cells organizations. Wherever sickle cell awareness needs spread, I am there. I also have a fashion line for sickle cell disease awareness called Devo Stars. I'm a professional model and I am a new author. I just wrote my first book. I don't have it, it has me. And yeah, it's been going pretty good. So all is exciting. And this is what I do. I love, love, love to spread awareness for sickle cell disease. And I'm so grateful to be here talking with you guys today.
Fantastic. And Pat, I'm going to ask you the same question. Can you tell us about yourself and your connection to sickle cell disease?
So I'm gonna start my story by telling a little longer story. So I am the third oldest of 10 children who was raised by a single father who lost his wife at the age of 32. And so from very early on, I knew that there were things that even myself as a young person needed to be aware of. And one of the things that I kind of just got tricked into was sickle cell disease. So I decided one summer that I wanted to serve my community, a community that looked like me. And so I researched what illness looked like African Americans, and sickle cell disease came up. And that summer, I was a young nurse. I volunteered for summer camp as a camp nurse that summer and fell into sickle cell disease. And I've been there ever since, trying to promote and elevate people with sickle cell disease because it's a cause worthy of that.
Wonderful. And we are blessed and lucky to have you be part of our community. So Tristan, I want to start with you, thinking a little bit about access. So what was care like for you growing up in terms of finding a provider and general awareness in the healthcare setting for you?
So I am in a very small city in Pennsylvania called Williamsport. Growing up here, I was the second person in the city to be diagnosed with sickle cell back in 1983. So back then, there was not a lot of knowledge about sickle cell. So I was kind of like the blueprint slash guinea pig when it came to all that. But the care was at my home hospital, which is Williamsport Hospital back in the 80s, was not really there. We had a very, very hard time even getting a diagnosis. Thank goodness there was a new doctor that had came into town when I was like 6 months, and he immediately came into the room because I would not stop crying, and nobody knew what was going on. And he looked at my hands, my feet, they were swollen, and he was like, "I think this child has sickle cell, test him." And so they ran the test, and it came out I had sickle cell. So it was on from there. But because of the rarity of what was sickle cell back in that day, like in this town especially, I had to kind of fight for care. So I randomly saw like really great doctors here. And if I did see a great doctor, a great care team, I had to go 45 minutes away to Geisinger in Danville, Pennsylvania. And that's kind of where I got my best care. But around here in Williamsport at that time, it was very, very limited and very few and far between. I actually had a stroke when I was 9 years old, and I was going to Geisinger because they didn't know how to treat me here. So they sent me in an ambulance to Geisinger, 45 minutes away, while I was, in pain crisis and trying to, get through that. And then when I got to Geisinger, they, said that I was having a stroke. Thank God I received the great care there. But it was like having to go 45 minutes from my hometown hospital in an ambulance all the way to Geisinger to receive care. That was kind of, very detrimental because everyone knows like when you're having a stroke or are in risk of a stroke, every moment counts. So the access to care here was not good. Thank God today it has changed. I have a great care team here. And I'm very proud to say that we worked well together. We collaborate well together. They listen to me. But back in that day, I kind of had to, and my mom especially had to advocate and really, go out there and fight for me to be seen and get the proper care so I can live here, live in this day and age, where I am healthy and be okay. So it just, it evolved, but at the same time, it was just like an upward battle, like getting to this point.
Yes, thank you for sharing that. And Pat, I want to ask you the same question. What was it like for you in your early career and even in the middle of your career, being able to administer care and the quality of care for people with sickle cell?
So when I first arrived in the sickle cell arena, I knew very little about sickle cell, and I had to do a deep dive into really getting to know sickle cell. But not just myself had that void. Almost all the nurses and the doctors at the institution that I happened to be at also had very little knowledge about sickle cell disease. And so when I arrived there, a lot of the patients would come in, and I was servicing primarily adults, but I also saw the pediatric patients. But the pediatric patients seemed to be treated more humanely than the adult patients. So the adult patients were not, they would come in and they would describe pain, and they would be told that the pain couldn't be that bad, or they were not given the medicines that they knew worked for them. And so it was a real hard struggle. There were times when the only thing I could do for patients was sit there and hold their hand while they cried in agony about the pain they were suffering as a result of sickle cell disease, and were not believed and were not treated in the way they should be treated. So that was really, really difficult. But I think that helped me to learn that I had to fight harder for people with sickle cell disease. I had to be more knowledgeable. And that was a big part of the fight, because if you don't know much about sickle cell disease, you can't teach other people about it. And in learning what people with sickle cell disease live through and experience, not just at the hospital, but outside of the hospital, and the things that they experience on a daily basis, it gave me, a toolbox that I could utilize to educate other people about sickle cell disease, and educate in a way that I could bring compassion, and help them to understand what people with sickle cell disease were really experiencing. So that's the kind of experience I had initially, and then I think, the ability to fight for people with sickle cell disease came about as a result of me watching the suffering of individuals with sickle cell disease, and then I had to craft how we could go about getting other people to understand, and administration to understand, the needs of this patient population. And so it was difficult, but it was worthwhile. The patients, I got to know the patients. We got to love each other. I felt like we were a family, you know, and that were it not for any of us being there, we would not have gotten the things that we got as we fought to make sure our sickle cell center became a center of excellence for people with sickle cell disease.
Fantastic. That's really inspiring to hear. And so I want to take a step back and think about some of the barriers that you see that exist right now. We'll also cover what we're sort of doing about these barriers. So thinking about barriers, what type of barriers exist across the healthcare spectrum? So thinking about insurance barriers, access to treatment barriers, providers. We'll start with you, Tristan. Just what type of barriers have you experienced in your journey with sickle cell?
Oh, wow. That's a great question. There's been so many barriers. Like I said, growing up in this very rural, small community, this small city, it was hard, even going to the ER and, being in crisis and getting treatment and getting believed. And, just have to fight for the care and the respect that I deserved as a sickle cell patient. So that was really hard. And then at the same time, um, when I got married, like I had Medicare, Medicaid insurance, and everything was great. Everything was covered. I was getting the treatment I needed, the prescriptions I needed, no problem, And then I got married in 2016, and they completely kicked me off of that insurance. So because, they were like, well, your husband has, a great job. You guys are okay. So you obviously don't belong with our program anymore. So good luck. We wish you the best, but we can't have you on our insurance. So that was a huge barrier and a setback. Thank God my husband has a, good job. And his job has great health care. But I just felt like so abandoned in that time, that transition time, because it was just like my whole life, I was so used to being on that insurance and having that kind of care and that quality care. It really felt like they, at least cared about me in that sense. And then to just be dropped like that because I found love, which you're supposed to do, and, got married and thought I was going to have my happily ever after, which I am now. But, the fact that I got married and they dropped me from that was a huge blow. But like I said, God always has a plan. And the care is great now. But I just felt like that was a time in my life where I was just like in this whiteout space. And I'm just like, how can you, on one hand, be there and say that you care about people with rare diseases and, be an insurance provider, but then just throw them off when, they don't meet the same standard that they used to or fit into the same box that they used to. Like they still have this disease, have this rare disease, and need the same care. But yet, because a little switch happened in their life, you completely just write them off. Like that's not okay. So that was a huge blow. But like I said, everything worked out, and now I'm better. My doctors, even to this day, they worked with me throughout that time as well to kind of when I was in that transition period of losing my Medicare, Medicaid, they kind of, helped me getting me more uh medicine that I needed just to cover that little gap. And so I really thank them. But like I said, that was just a huge detriment and a huge blow, but it all worked out.
I understand. So I'm hearing that with that change, you had a moment where the insurance changed and there wasn't much
Hmm.
support for
Hmm.
that gap in coverage. So it interrupted your treatment, your ability to see the doctors, et cetera. Am I hearing that correctly?
Yes, yes, it was
Mhm.
completely like just a white space. Like I said, I just felt like so thrown to the wolves, you know what I mean? But God always has a plan and it worked out.
Yeah. And Pat, I want to ask you the same question. So in your work in the past and your work currently, what barriers exist for you on the healthcare spectrum, providers, hospitals, coverage, et cetera?
So there are a lot of barriers. I think number one barrier is knowledge of sickle cell disease, because there are so many healthcare professionals who don't know sickle cell disease and don't understand it, there's a lot of judgment on people with sickle cell disease. But additionally, Tristan said insurance. Insurance is a major barrier, and it's a barrier because there's a lot of lack of knowledge on the part, not just of providers, but on the part of individuals who seek their health care insurance. So oftentimes they'll go to an institution that will tell them that in order for us to serve you, you'll have to take this insurance. And so a lot of our individuals who had both Medi-Cal and Medicare gave their Medicare and Medi-Cal up for an individual insurance, which didn't really meet their needs, but they had no understanding of the fact that they wouldn't have the same services available to them that they had when they had those two independent insurances. And so just getting families and providers and individuals living with sickle cell disease to understand the importance of knowing what insurance is all about, and how do you select the insurance that best meets your needs based upon what institutions you plan to go to, what institutions actually service people with sickle cell disease, that do have good knowledge about sickle cell disease is a real major on part of patients living with sickle cell disease. And then another barrier is just getting people to understand sickle cell disease. So the individual knows how their sickle cell disease manifests and the things they go through, but getting people to believe them as they report their experiences with sickle cell disease, and then also getting healthcare providers to believe and to support them. So there are a lot of shortcomings related to insurance and to life with sickle cell disease. School systems don't understand sickle cell disease, and so they don't know what to do for individuals with sickle cell disease. Hospital settings have difficulty. Pediatrics is a little better than adult, and probably because children, though they experience sickle cell episodes and stuff, the damage that happens, the cumulative damage over time is profound in adults. And there are many people who don't really understand that. And so even when applying for services with insurance companies, because the person manifested as a child this way and now manifests as an adult this way, they often aren't given the services that they need to prevent further damage from sickle cell disease, that damage that we can prevent. And I think I was sharing at one time with another group that, when I first came into the sickle cell arena, there were institutions of excellence, and those institutions were vetted regularly. So you couldn't just call yourself a sickle cell center of excellence. You had to be granted the right to be named as a sickle cell center of excellence. And I think we kind of have lost that over the years. And so everybody claims that they offer excellent care in sickle cell disease, and when clients get there, they find out that's not the reality. And so I don't know how we balance out, again, making people understand that sickle cell centers of excellence should really be centers of excellence that offer the best possible care for people with sickle cell disease. And for those that don't know and understand certain things, do a deeper dive into on a national level of understanding sickle cell better and the provision of services to people with sickle cell disease. So those are the kind of things that I ran into. Additionally, I ran into my lack of knowledge initially. And so I had to pour into learning more about sickle cell disease. I remember at the time that I came on, there was a medicine that was being used called Demerol. And we don't use it much anymore, but it worked for a lot of patients. And the problem with Demerol is there was always the concern about addiction. And we had people that were 60 years old and they were still struggling with, you might become addicted to Demerol, even though you've been taking it for 50 years, So those kind of things, understanding of medications and the effects of sickle cell disease are really, really necessary. And those were all barriers to us because we lacked that knowledge at that time.
Wonderful. Thank you for sharing that and also highlighting some of the things you did to educate yourself. So we talked about some of the barriers, but I want to now move into sort of what are we doing about it. So Tristan, you had talked about how you had to educate the system and you've worked in awareness. So I guess what are you doing in your support team? Because I know we mentioned mom. What are you all doing to sort of change the system in your neighborhood? What are you doing to address some of these barriers in your community for sickle cell?
Well, yeah, my mom is always right there with me. She's my ride or die forever and always. But luckily today, as I'm older and I've watched her advocate for me, and I've found the community that I found here and among other sickle cell warriors around the world, like we're such a community now that I feel like the need for sickle cell awareness has grown. So I'm always out there on the front lines. I always want to, show up like today when there's something that needs to be talked about and sickle cell awareness needs to be brought to the forefront. I'm always there for that. My mom is actually in the process of right now creating a CBO here in Williamsport, Pennsylvania, because we have probably, I would say, like 13 to 14 new sickle cell warriors in our area, but yet they don't have anywhere that they can get, the resources. Our nearest home group, I will say, is in Harrisburg, Pennsylvania, which is about an hour and like 45 minutes away from here. So for them to have to go from here to Harrisburg to get that knowledge, is just unfair. So me and my mom travel back and forth to Harrisburg. I'm a part of the South Central Sickle Cell Council of Harrisburg, Pennsylvania. So I kind of relay what the need is here to them, and then they help, bring that collaboration together so we can start the CVO here and get our sickle cell warriors here and our hospital actually updated on the new treatments, on the new therapies. We're hopefully going to have a full sickle cell center at our UPMC here. And so it's just very more hopeful than it was. And me and my mom actually, I would say, especially my mom, when I was like 18, 19, she went to the nurse administrator during one of my crises and was like, listen, it's not fair that Tristan, has to come in and deal with what he has to deal with, number one. Number two, you guys don't make it easy because you're lacking knowledge. And number three, the fact that there is no person under the specific doctor here in your ER that is designated to sickle cell or knowing about sickle cell, like that's not cool. So we actually started a program back when I was 19, and we talked to like the head of the ER and got them updated. So we're just constantly spreading sickle cell awareness here. And as I said, I'm not going to stop. My mom's not going to stop until we can definitely make sure that every sickle cell warrior here, near, far, whatever, has the same access to care and the same great health opportunities and gene therapies and everything that the big cities have, because that's only right. And I just feel like even though, sickle cell is more talked about, we still have leaps and bounds to go. But I do feel better in this day and age that we are making so much progress and getting so much more attention than that we have in the past. So that's a plus.
Wonderful. And Pat, I want to ask you the same question. So what steps and actions are you taking or have taken to ensure access to quality of care to sort of address some of these barriers?
So I think probably the biggest step is just using my voice in places where it needs to be used. I had a patient that I haven't serviced in over 20 years call me the other day and said, "Can you meet me at the hospital to see the doctor?" So I do a lot of advocacy. I will go to point of care settings to make sure that that the voice of that individual is heard. So I'm doing that. We do a lot of legislative kind of things. Fortunately, we were allotted some money to provide services to people with sickle cell disease, and not just, the basic services, but babysitting when the person is in the hospital, you know, um, having someone come that's vetted to make sure that they are reliable to take care of the children of a person in the hospital, helping them to get housing, just doing a lot of different things, but also doing a lot of education with both first-year medical students at University of Southern California and other places to make sure they have an awareness of sickle cell disease, because oftentimes they don't. And fortunately, the last 2 years that we've been doing that, our course related to sickle cell disease has been proclaimed the #1 course for first-year medical students by the first-year medical students. And our hope is to follow those medical students through medical school, giving them surveys during the time they're in there and coming out with, how we can better service those students to better understand sickle cell disease so that they can better translate that into care for people living with sickle cell disease. So that's one of the things that we've done. We do a lot of education in other schools. Adrian Shapiro and I are trying to put together a program with the pharmacy students because we want to better understand the medications that people with sickle cell disease are currently using, the proposed ones, and what might work better for them. And then just talking with other people. One of the programs that we did in the past that really ensured better care for people with sickle cell disease is that the patients had health insurance through the state, but there was an opportunity. Fortunately, California has an additional health care program, and it's called Genetically Handicapped Persons Program. And it's an insurance that provides additional services, but it also allows us to see that individual once a year for a total physical if they're part of that program. And so they get a physical that looks at every system and stuff, and that information is sent back to their doctor who takes care of them so that they can better understand what's going on with that person with sickle cell disease. So there are a lot of creative kind of things that can be done out in the community to make a difference. And then the other thing that we're really promoting is good and speedy care, because we can save insurance companies a lot of money if we can get patients and treated well and out of the hospital in a shorter period of time. And so our focus is really on how we can make life better for people with sickle cell disease, decrease the cost of hospitalization, and ensure that they get the best possible care. So those are the kind of things that we've been doing. And I'm working jointly with Cayenne Wellness and Access Advocacy in LA, but I'm also International Association of Sickle Cell Nurses and Professional Associates, where we've been doing education all over the world to make sure that people with sickle cell disease are better understood and better treated. So just, and then just talking in the community, meeting up with people at churches and sharing information, and just making sure that there is a plethora of information out there that people can incorporate and change the way they think and prevent all the judgment that happens to individuals with sickle cell disease, and also to teach clients how to stand up in situations that they need to stand up in, and how to utilize advocates in those situations where they are not able to speak for themselves. The one thing I always tell individuals with sickle cell disease is when you're sick, you cannot be your own self's advocate. And so just to teach them the reality of utilizing services that are out in the community and helping to develop services that they feel are necessary for a better life with sickle cell disease.
Great. And so we have a few comments here. We have about 3 minutes left in your session. So the first one here is, the clinical education system has lagged behind in hematological disorders. Nursing schools may only have a brief paragraph on this subject. 10 years ago, I reviewed a dozen nurses' texts, and one book had one chapter on hematology. So I think this is a comment sort of solidifying or reinforcing what you were saying, Pat, when you were starting your nursing career. And then I also want to read this one. It says, I just want to say thank you to Pat. She has saved numerous lives, and her passion is second to none. So I want to ask you one more question in the last 2 minutes. What gives you hope for sickle cell disease? And we have 2 minutes, so that leaves about 1 minute for each of you to answer that. We'll start with Tristan.
So what gives me hope is, definitely the advancements that are being made, the new gene therapies, the new, treatments that are coming out. They give me great hope that one day we will have a universal cure for sickle cell. And as I said, the more awareness that is being brought in this day and age, be it, social media, the media, television, I think every type of awareness to be brought to this disease is just enhancing, the awareness factor and getting it out into the world. And I think that's amazing. So I'm very hopeful for the future. And I know that we've come a long way, but we also have a long way to go. But I feel like we're probably like 75% more there than we were back in like when I was born. So I just think that it's a beautiful day and age that we live in, but we still have leaps and bounds to go. But with meeting myself, Pat, you, Ashley, and all the other orgs and the warriors in the world, I know that we will definitely get to the place where we have our universal cure and sickle cell will be a thing of the past. And that will be because all of us working together and doing great things like this. So that's my hope.
Wonderful. And Pat, what gives you hope for sickle cell in the last 60 seconds here?
So what really gives me hope is the increased life expectancy for people with sickle cell disease and the better care in some parts of sickle cell disease. But what really gives me hope is people with sickle cell disease having a voice. When I came into sickle cell disease, they did not have a voice. No one with sickle cell disease was speaking on their own behalf. And now I see organizations and people who really care about folks with sickle cell disease pouring into the sickle cell arena, even though we still have a long ways to go. I just feel very hopeful that individuals, will have the same ability to go to school, graduate, um, have a life that's productive and that's meaningful and that's not filled with only suffering and find that path in their life. Not everybody with sickle cell disease is at a point where they can't do anything, where they're totally disabled. Now we see people with sickle cell disease who have explored eating healthy, exercising. Before that, it was like families believed they couldn't do anything. Families are now buying into promoting health for people with sickle cell disease. And though their health may not look exactly like the quote unquote normal person who doesn't have sickle cell disease, they are in many instances very healthy, very committed, very self-directed, and pouring into other people with sickle cell disease. And that community having a voice gives me hope for people with sickle cell disease.
Wonderful. Well, thank you so much, Pat and Tristan, for sharing your insights and your reflection. And we really, really are grateful for you to have joined us today.
Thank
Thank you
you.
for having
Ashley.
us.
Hey, thank
Anytime you
you.
need us. See ya.
Hello, everyone. I'm here to introduce the next session titled Leading the Way, Payers Discuss Sickle Cell Coverage Initiatives. And today we'll be hearing from Dr. Emily Sau, a commercial payer, and Dr. Jennifer Strohacker, a state Medicaid director, as they share their strategies and initiatives to improve access to care for individuals with sickle cell disease, highlighting current efforts to expand coverage and address disparities in treatment. So first we'll hear from Dr. Strohacker, and then following Dr. Strohacker, I'll introduce Dr. Sau, and then we'll have them join together for a Q&A session at the end. So Dr. Jennifer Strohacker is a healthcare leader and an advocate dedicated to improving access to care and patient outcomes with a focus on Medicaid programs and healthcare innovation for underserved populations. And at this time, I would like to introduce Dr. Jennifer and have you unmute your mic and begin your presentation.
Morning, good afternoon to those of you who are attending this conference today. Thank you for the opportunity to be here and share some of the exciting work that we are doing at Utah Medicaid to prepare the way for cell and gene therapies, specifically for those who suffer from sickle cell disease. My name is Jennifer Strohecker. As noted, I have a background in pharmacy, and so to see these medications come to market and be available treatments for our population is just really astounding to me, and I know will be life-changing to the individuals that they serve. I've been in my role as our state Medicaid director for Utah for the last 3 years. And today I'd like to share just for about 10 minutes, go through the work we've done as a Medicaid agency in being able to prepare the groundwork and also the pathways so that the people who are identified as being eligible for these treatments are able to receive them timely and that their families and their needs are properly met. So next slide, please. Throughout my presentation, I'd like to just walk through how we've actually really developed pathways so that people who are diagnosed with sickle cell disease and who are eligible for these medications are able to get them in a streamlined way. We're going to talk about how we've worked both from a coverage policy perspective as well as a reimbursement perspective from the Medicaid state perspective, and then working on how we've worked with stakeholders in our community, and then really driving down into how we're aiming to serve the individual member needs. Next slide, please. So first, I'd like to just give a background to this. You know, we knew these therapies were coming now for some time, and we've been thinking about them, I'd say, for almost 2 years. As a state agency, we've actually been having conversations with stakeholders and really been trying to wrap our head around how we are really going to manage these new drugs that are coming to market and really offering cure solutions for people who have lived with chronic disease. It's really important for us to consider because as these medications are delivered, we know some of them are really coming to market with an accelerated approval pathway. There's a lot of interest in these drugs, and certainly from the advocacy community and our provider community, we really want to understand how we can actually make these available to people, but also how we manage them from a reimbursement perspective. Here we are paying multi-millions of dollars upfront for a cure that we hope and believe will really maintain the promises and the treatment outcomes that we believe in, and that we hope that these studies have shown, but that they last. And so really in doing this, we've engaged stakeholders from across our state for the last couple of years in really having these conversations. When we think about it, and I know we have a commercial payer perspective, but from the Medicaid perspective, and thinking about this, I've engaged our state board of pharmacy, our public and private payers, because as we think about this, we've tried to think about statewide solutions to this. And Utah is not the biggest, most densely populated state in the country, of course, but we have academic centers that really deliver high quality care and will be sites of care for administering these medications. And I think some of the opportunities we're looking at is how we can do this not just through a Medicaid lens, but how we can do this holistically as a state to really provide the best solutions and best therapies and best sort of outcomes for the individuals that are served through these medications. I brought this to our legislature at least a year plus ago. We started talking about cell and gene therapies and really laying the groundwork so that our lawmakers understood the financial impact, but how that cost was, what that was tied to, and how that cost was tied to the outcomes of treatment. And this really is a shift in dynamic when we're looking at state budgets that are run from a year to year perspective. How do we really develop awareness and actually have appropriate funding and buy-in and engagement from state stakeholders so that we're prepared and we're not surprised by this, but we also have support. So really we had legislative engagement early on. In fact, even a year ago, I already had a line item on my state budget created for something that we call ultra high cost drugs. So we created a new term in our state that fits into our Medicaid budget, but is also very visible for lawmakers, but also external stakeholders, that really sets aside a line item budget for these drugs that we're terming ultra high cost drugs. We've defined these as medications that are costing greater than or equal to $1 million per dose. And so when we look at sickle cell treatments, these fall right into that. And we actually had funding set aside even last year as we're forecasting in our state drugs that will be approved that year and how many individuals in our state on the Medicaid program that could qualify for this. We're setting aside money in advance, so we have some guarantees around funding and sustainability for this as we're looking forward. So I'll just say that's our background. I'd also say that it doesn't just look at funding. It's really important for us to think about the journey of the patient, the individual, as they may initially receive that medication as a Medicaid enrollee, but may move along a clinical pathway of care that may take them out of Medicaid and move into a commercial payer space or other payers that our interest as a state is really thinking longitudinally many years so we can follow. And we're thinking about like a statewide registry that can really gather this data and really follow individuals longitudinally so we can actually have good data in making sure that these investments in cell and gene therapies are really holding their value over time, and that we're able to clinically monitor and measure those outcomes. Next slide, please. So I'm going to get into some technical details here about the pharmacy program here in Utah, our Medicaid program, and really walk through some nuts and bolts sort of planning that we did to ensure that we had the right infrastructure design to be able to be prepared for this. I'll just say, first of all, in our program, we serve today about 360,000 individuals. So we're a middle-sized state when it comes to Medicaid programs. And when you look at this, we actually have 5 pharmacy programs in our state. We have a fee-for-service pharmacy program, and then we have 4 different managed care programs that also each have a pharmacy benefit. Okay, so we today have our fee-for-service program handles about half of our pharmacy claims due to significant carve-outs on the behavioral health side and other special disease states. But that's sort of how it is. So if you think about a member or an individual could be enrolled in fee-for-service pharmacy or in select health, there's a lot of maybe perhaps differences or barriers that a person could face as they move from one program to another. And as we looked at cell and gene therapies, it was of interest for us to really unify our coverage design and our reimbursement pathways so that they weren't getting 5 different experiences from a provider perspective or from a member or individual patient perspective as they were moving through our different Medicaid programs. Next slide, please. So one of the first things we did was look at our coverage policy. So from a Medicaid perspective, when you look at, are you going to pay for these drugs? Well, we know right out the gate that Medicaid, number one, is a primary payer of a lot of medications that are used for rare diseases. And a lot of individuals who suffer from chronic high-cost conditions are eligible for Medicaid. And in fact, if manufacturers like the drug manufacturers that make cell and gene therapies participate in the Medicaid drug rebate program, Medicaid programs are required to cover this drug. So one of our first questions that from a commercial payer might say, do I cover this drug or don't I? That's not even a thought for Medicaid. We cover these drugs. And so now the question is, we are going to cover them, but how do we design a coverage policy that optimizes these drugs so that when an individual is found to be eligible, we can actually provide a very streamlined approach that is also timely so that the person can get that medication right when they need it. So our goals, when we thought about cell and gene therapies and these sickle cell treatments, how do we design coverage policy that ensures that when that request comes in, it has a timely and quick review of these approval requests and approval so the person says, yep, they meet criteria, we approve this drug. So with this, one of our other goals was that we apply a uniform coverage policy. So they weren't getting 5 different policies. If they were to go to a different pharmacy program, we wanted one. So in order to do this, one of the first things we did was we actually carved out those ultra high cost drugs, cell and gene therapies that cost more than $1 million per dose. We actually took them out of those managed care plans and we put them into our fee for service program so that they were managed in one central place. We did this about more than a year ago. We started this work and already moved forward with carving the drugs out and creating a policy specifically for ultra high cost or cell and gene therapies. With this, we are able to define uniform prior authorization criteria. The way we do this for all of our high cost drugs, but specifically for sickle cell disease, is we develop coverage criteria. We run it through our boards and our committees that are made up of external stakeholders, providers and pharmacists, and even members and other stakeholders in our community. But we also work with the experts. We have our centers of excellence and our providers up at our university centers that have participated in the clinical trials. And we work with them in designing these prior auth criteria so that they buy into this criteria and it actually meets the needs of the individual. So that was developed. And then because we can carve out the drug cost to fee for service, but that individual may be enrolled with one of the managed care plans. They could be enrolled with Molina Healthcare or Select Health, some of our managed care providers here in Utah, and they're the ones coordinating all the other aspects of medical care, behavioral health care. And so for us, it's really important that while we put the drug policy in a fee for service setting, we needed to ensure that there was really good, tight communication and coordination around those other aspects of care that are necessary for the person to get timely coordination and coverage of all those other aspects of what it would take for them to be appropriate candidates and to successfully get this. So we developed and worked together with our managed care plans to develop an SOP. We'd be happy to share this with you, but it's meant to optimize care coordination and communication. Next slide, please. So next, we're looking at reimbursement policy. And if we could go to the next slide. I think the next aspect is how do we pay for these? So our goals here was to really look at, first of all, and I think from a legislative perspective, as we're looking at Medicaid dollars, these are all state dollars, taxpayer dollars, right, that are going into these. We really wanted to think about how we control cost, have transparency with reimbursement, but it also optimizes our outcomes for people. So we want to make that investment. We want to make those pathways clear, but we want to ensure that when we're paying $3+ million for these therapies, that we can get the outcomes that we want for this. So I'll say, and I'm sorry for some of the formatting changes that happened here on this slide as I converted from Google down to PowerPoint, but you could follow along here. One of the first opportunities we had as a state agency was to engage in value-based agreements. In order to do that from a Medicaid perspective, we needed to be able to have authority to do that from CMS. And I know CMS was an earlier presenter today, so they may have touched on these things, but we immediately as a state, Utah, we applied to be able to say, we want to be a state that it has the authority and the ability to engage in value-based agreement. We got approval for that about a year ago from CMS. And then additionally, as CMS was preparing to release its cell and gene therapy access model, we stood right up and I've talked to the head of CMS, and we've been in direct conversation saying, we want to be part of this work. We believe in this work, and we want to be a state that applies to this and is an early adopter to this model. So we have our application drafted. We are working on that now and are prepared to submit that in the upcoming weeks so we can be part of that cell and gene therapy access model that will introduce sickle cell treatments through that model to our state, to our the patients and the individuals in our states. I've already mentioned too, the ability to be able to control reimbursement really was necessary too by carving these drugs out to our fee-for-service program. And with this, we were able to look at the way these drugs were reimbursed. Some of these drugs, as you know, may be infused in a hospital setting. Some cell and gene therapies may be infused outside the hospital setting. I'll talk specifically around sickle cell treatments, which will be given in a hospital setting. One of the challenges we've had with reimbursement is that the drug itself might go into this big bundled payment that happens on the hospital side. And it was really important to us, as you look at these sort of bundled payments that might account for that whole stay, there might not be proper visibility around the cost of the drug and what was put into that hospital billed charge for the drug. And that's called a DRG, or diagnosis related group, is how we pay those hospital claims. So one of the steps we had to take with our policy was to carve out these cell and gene therapies from that bundled payment so that we could reimburse separately for these drugs. It also created a level of transparency so that when we were reimbursing for it, we actually created an invoice form so that when the doctor or provider submits that prior authorization request, the hospital themselves has to actually submit their invoice cost to the state. So they can say to us, this was our cost. We paid, $3 million for this treatment, and we had a rebate that brought it down to here. And they have to send that confidential information to us so that we can sign off and say, we agree to pay this to you. And then they have confidence as they order this drug in, they will get reimbursed for that whole cost and will be made whole. And then we can also, with our contracting with manufacturers, have evidence to say, this is what we paid for the drug. This is how we're keeping our hospitals and our payer groups accountable to pay the actual acquisition cost. And it's important from a manufacturer perspective, as we engage in value-based agreements, if there is any sort of deterioration or sort of clinical milestones that are not met, that they have assurances and a promise to pay us back for some of that investment we made in the drug. So that is sort of the infrastructure we set up again around our reimbursement policy. Again, we're happy to share through sickle all of these sort of this infrastructure that we have. It's all publicly posted on our website, and we're happy to share that after this presentation. Next slide, please. Last but not least, I really want to just share how, as we've worked through this process to get kind of our back end set up, I talked to you over 2 years ago, we started engaging with stakeholders on how we're going to tackle cell and gene therapies and really work from a statewide approach in advancing care and access to these therapies and really the holistic care of individuals who receive them to ensure their success when they do. So I'll just run through this. I know I'm running out of time here. First and foremost, I'm running now the Medicaid agency as an administrator of a state program, but my background is patient care. And as I trained in Philadelphia and had many experiences through my years of clinical working, I worked frontline with individuals who were suffering from this disease and other rare conditions. And the role I'm in today, patients are center of that, in really, really optimizing outcomes and promoting access to care for individuals who may have a really hard time really truly overcoming some obstacles, but making sure they can get the treatments that they qualify for. So patient care and working directly with patients and getting their voice is central to this process for us. And we're still in the planning phases, but as we really evolve and build a better system of care, really engaging with patients, their families, their caregivers, that's an essential component to make sure their needs are being met, that all the gaps are being covered, and that it's successful for them. I've talked a little bit about providers. We live in a smaller state with centers of excellence. We work directly with providers and their care teams in a holistic approach that are delivering these medications. We know well in advance when they've identified an individual who's qualified for this. We're automatically working and coordinating care. We have individuals right now who are eligible for this. Our managed care partners are key to that. It's as the model of care. We look at all those different people that fit into that, and Medicaid has a role. We are not the only role. There are other pieces. We want to ensure we've identified all of that. I've touched on manufacturers, optimizing our value-based agreements, making sure that we are current with research as it's happening, making sure that we are as robust as we can and making sure people have and our policies are really upfront and meeting current standards of care. And then, last but not least, regulators. I think the other piece that I would just say, very last but not least, is community-based organizations. And I heard this mentioned on the last panel where we're talking about community health workers, people with lived experience, churches, community members, and all of those really who lift up and help support individuals, bringing those people to the table and understanding how their roles are essential. We have a rare disease advisory council that was set up as part of our legislative process in helping support individuals living in Utah who really have sort of these rare conditions and helping them thrive, right? Really helping them have the resources they need. And they are a great conduit. I'm working with the Rare Disease Advisory Council to bring members and patients, individuals, but also those other community stakeholders to the table as we build up this process and really and bring it forward so people can really hopefully have the best outcomes through it. So with that, thank you for my time. Of course, we'll have time for questions after.
Thank you so much, Dr. Strohecker. At this time, I would like to introduce Dr. Emily Tsao. Dr. Emily Tsao is the Medical Policies Clinical Pharmacist at Premera Blue Cross, where she leads drug clinical policy development across the medical and pharmacy benefit for over 2 million members. She has experience overseeing drug utilization management strategy, drug pipeline surveillance, and clinical programs. So at this time, I would like to introduce Dr. Emily Tsao, and if you could unmute your mic and begin your presentation at this time.
Thank you so much, Ariel, and thank you to everyone so far for your attention and participation. So when it comes to addressing disparities, specifically in formulary development, we've acknowledged within Premera that there really is a need for the pharmacy team to lead the charge in bringing really these considerations to the forefront. In meetings like our independent P&T committee, which is the Pharmacy and Therapeutics Committee, we have an internal medical policy committee and other forums. Though health disparities in sickle cell disease and other disease areas are important to the decision makers, there can just be so many other demands on their time and attention. So we have found that some targeted questions such as the following may be helpful to guide that conversation when it's appropriate. So questions such as, will the drug be used in an underserved population? Are there population-specific differences in pharmacodynamics, pharmacokinetics, or other areas to take into consideration? What barriers to access for this treatment could members face? How can we help? What education do providers need to ensure optimal use of the drug? What challenges does the disease pose in a patient's daily life? How may the drug under review help overcome these challenges? What socioeconomical, logistical, geographical, or other factors might hinder successful use of a treatment? And what cultural factors such as maybe distrust of the healthcare system might hinder successful utilization of a treatment? On the next slide, are resources that we utilize to address the questions we might ask or receive, such as speaking with physician experts that treat the disease, utilizing resources provided by or speaking to patient organizations representing the patient population being discussed, targeted literature searches focused on the patient population of interest, and ICER, or the Institute for Clinical and Economic Review, reports if they're available. On the next slide, to navigate health disparities in payer organizations, it can be really helpful to incorporate the patient perspective or the patient voice into decision-making and internal education or trainings. So the central role of a Pharmacy and Therapeutics Committee or P&T committee is to objectively appraise, evaluate, and select drugs for the health plan or pharmacy benefit manager's formulary. So to incorporate the patient perspective into this process, patient organizations can contribute to these P&T committee meetings by providing patient journey information or by giving written or verbal testimony at P&T meetings, or maybe even any subcommittees that happen ahead of time prior to the big P&T meeting. Payers who organize P&T meetings can also incorporate publicly available information on the patient's lived experiences into the P&T review process as well. In most payer organizations, the care management, or sometimes it's known as the case management team, is typically made up of clinicians who usually support patients with complex conditions. So at Premera, we have received feedback that, personally, our care management teams really appreciate and find value in receiving training on the patient's point of view and what health disparities patients with a particular condition may face, particularly with rare diseases. So they've noted that they use this information in their interactions with patients. In addition to internally created education, we have previously also invited patient organizations and patient advocates, such as folks from this organization, to provide that live patient journey education sessions to our care management teams. So lastly, our organization frequently uses, again, those ICER reports in our decision making. In particular, we find the insights on the patient perspective and the payer recommendations, which are in line with their cornerstones of fair drug coverage criteria white paper, particularly useful. But overall, incorporating the patient perspectives into decision making and internal education can not only help an organization navigate health disparities, but also avoid any unintentional access barriers and promote patient-centered care. On the next slide, I just wanted to share some lessons learned from our experience supporting sickle cell disease members, specifically by exempting members or patients with sickle cell disease from our opioid criteria. So we found that taking advantage of any operational efficiencies available in the electronic prior authorization or EPA and the utilization management process or process is very helpful. Clearly communicating at every opportunity in the medical policy and provider and member prior authorization response letters, in the electronic prior authorization questions that members with sickle cell disease are exempt from the opioid criteria, and providing education to internal teams about the updates so that they can share this information with providers and patients when needed, really to help decrease the administrative burden for providers and patients associated with filling the opioids for members with sickle cell disease. So lastly, like with every implementation, we found that having a clear champion, having a leader to support the operational updates, and someone to serve as the role of a project manager can also really help align goals and support a successful implementation. On the next slide, I just wanted to switch gears to think about the sickle cell gene therapies. Per ICER, again, the Institute for Clinical and Economic Review, coverage of gene therapy should be provided in a comprehensive fashion, including coverage for travel, ancillary care, pre and post procedure, including mental health care, fertility preservation, and out-of-pocket financial burden. So all elements must be addressed and aligned in order to reduce the risk that introduction of gene therapies for sickle cell disease will create a new health equity concerns within a population that has had to bear many years of historical and ongoing discrimination. So given that treatment with a sickle cell gene therapy can require significant travel, payer organizations can help support members with sickle cell disease considering treatment with a gene therapy by educating travel benefit decision makers, such as employer groups, on the importance of having travel benefits available for these patients. Also, the infertility risk associated with the sickle cell gene therapies can be a big psychological burden for patients considering treatment. So payer organizations can greatly help members or patients with sickle cell disease considering a gene therapy treatment by educating fertility preservation benefit decision makers, such as employer groups, on the importance of having that comprehensive fertility preservation coverage available for these patients, including drugs required for fertility preservation treatment, the procedures required for fertility preservation, reproductive specialist counseling, infertility treatment following fertility preservation treatment, and other related services. Lastly, on the last slide, looking forward, I just wanted to note that Premera is evaluating how health disparity considerations are really reviewed during our P&T committee meetings. Below, I've copied a portion of our quote-unquote value matrix within our standard monograph template, and we're currently reviewing really how this section and other areas of the monograph template can be modified to better highlight relevant health disparity considerations within a review. We're also looking at opportunities to provide annual health disparities trainings to our P&T committee members, medical policy committee members, and other clinical team members within Premera. And lastly, we're also looking into opportunities to partner with some of our key provider systems in our network to provide emergency department sickle cell disease, racial bias, and treatment disparities training. So in closing, we really acknowledge that structural racism exists and it impacts the provision of healthcare for patients with sickle cell disease. And we seek to integrate proactive strategies to improve equity, beginning with the education and training within our sphere of influence. And with that, I will turn it back over to Ariel.
Okay. Thank you so much, Dr. Sau, for your presentation. At this time, I would like to open up Q&A, and we are monitoring the Q&A box. And I know there was one question, Dr. Strohecker, that you answered related to funding. Was there anything else you wanted to add to that question? It was the question I can reiterate. Is this funding on top of Medicaid? Yeah, is this funding on top of Medicaid funding that is already set aside?
Yeah, that's great. We created it as a line item on our budget that was a unique line item. So we have a pharmacy budget, right? And for just to prepare for what we believe will be happening and make sure that there is money set aside, we created a special line item for these medications so that we're prepared for it. So yes, it is a unique line item on the state budget.
Thank you. And then checking to see if there's any others. And then I had a question. So how are payers and Medicaid programs supporting innovative care models like telemedicine and patient-centered medical homes to improve sickle cell disease care?
Yeah, thank you for the question. First of all, we learned so much through the COVID pandemic around telehealth services and the ability to deliver care through this modality, and have certainly modified what were our pre-COVID policies to allow a really robust telehealth standard without barriers. We, for the state of Utah, have maintained telehealth modalities for audio only, audio visual, and all of these. We have, many different rural or frontier areas in our state where individuals may not have ready access to that specialist, or perhaps they don't even have transportation. While we have a transportation benefit, it could be a barrier for some reason. So we reimburse broadly for telehealth services, for services that qualify, which are broad number of services, unless it requires like an in-person assessment and evaluation. We cover that, and we cover it at the same rate that we do the in-person rate. So I'll say that's one lesson learned from COVID that we were able to implement for our state policy. I believe telehealth is a fantastic modality that really I think states should embrace in order to provide the type and time of care that individuals need. And then next, the medical home model is something that we also have looked at. One of our objectives in looking at an approach that we recognize silos of care from physical health, behavioral health, different care teams really does not optimize the outcomes for individuals. And we work diligently to really look at holistic integrated models of care, and have a couple models in place right now that look like a patient-centered medical home. In the managed care model, it's designed just a little bit differently, but this type of model we're looking at for individuals who receive therapies, and I have my medical director on this call actually, this is the type of model we're putting a medical home around. And it might not be a formal medical home model with regard to CMS recognized models, but that is the operational tools we're putting in place so that these individuals can succeed from start to finish throughout those many months of treatment and duration, so that they can thrive and really achieve their best outcomes through this. So thank you for saying that. And I am excited to share what it looks like when we actually begin delivering this for patients.
Dr. Sau, did you want to comment on that question?
No, I think since it was related specifically to Medicaid and we're a commercial plan, I think Jennifer covered it really well.
Okay. Well, unfortunately, we are at time, and I want to be mindful of that. So thank you both so much for your wonderful presentations. And at this time, I would like to cue up the slide for the break. We ask that you're able to return at 2 p.m. Eastern. Thank you so much.
All right, let's go ahead and get started. So once again, I'm Kelly Hawthorne from Sickle, and I'm the Director of Community Programs. And I have the absolute pleasure of welcoming Elizabeth Hassett to our summit today. And Elizabeth is going to be talking to us about CMS Cell and Gene Therapy Access Model. So in this session, Elizabeth will provide an in-depth overview of the CMS Innovation Center's Cell and Gene Therapy Model, highlighting how it aims to enhance access to cutting-edge treatments for sickle cell disease while addressing challenges related to affordability, implementation, and equitable care delivery. And a little bit about Elizabeth. So Elizabeth is an associate at Levitt Partners based in Washington, D.C., and through her work is also an advisor to the Sickle Cell Disease Partnership. At Levitt Partners, Elizabeth supports clients and multi-stakeholder alliances by managing projects and providing strategy on health policy issue areas related to rare diseases, access to treatments, drug development and pricing, and pharmaceutical supply chain management. Before joining Levitt Partners, Elizabeth was a law clerk at the Centers for Medicare and Medicaid Services. She additionally served as a law clerk at the Maryland Office of the Attorney General for the Maryland Department of Health. So with that, thank you. And once again, welcome, Elizabeth.
Hi, everyone. Thank you so much for having me. And as Kelly said, I'm an associate at Levitt Partners, more pertinently today an advisor to the Sickle Cell Disease Partnership. A quick note on the partnership, we're a multi-stakeholder alliance that focuses on federal policy objectives to ensure timely, sustained, high quality, equitable, coordinated, all the words, care for individuals with sickle cell disease. And our members span sickle cell nonprofits to industry, trade associations, and individuals with sickle cell. Levitt Partners is the convener and manager, but the partnership, we really try to make it as member-driven and consensus-based as possible. So today I'll be giving an overview of the cell and gene therapy access model, which I know we've heard some about today already, but I'm hoping to get more into the specifics of how it functions, as well as the policy implications that really have been identified by the partnership. Next slide. So here, getting into an overview of the model. Next slide. So overall, the access model is designed to have a value-based payment structure that emphasizes using outcomes-based agreements to incentivize pharmaceutical and state participation. The Innovation Center developed the model in response to President Biden's October 2022 executive order on lowering drug costs. And what it really does is give CMS the ability to negotiate the key terms for outcomes-based agreements between gene therapy manufacturers and state Medicaid programs for rare and severe diseases. And of course, sickle cell is the first focus of the model. That's especially important given that Medicaid is a disproportionate payer for individuals with sickle cell, and of course, the substantial health disparities and inequities experienced by individuals with sickle cell, which we've heard about today. Participation for both parties to the agreement is totally voluntary, though recognizing the inherent high cost of gene therapies and the potential for long-term healthcare savings, there is an incentive for manufacturers and states to use the model. Functionally, CMS is negotiating on the key terms of the agreement. So that includes the pricing and outcomes measures that ultimately form the individual contracts between the manufacturers and the states. So things like rebate calculations and amounts, the duration of the agreement, and data sharing arrangements. In effect, manufacturers provide supplemental rebates, states implement a standard access policy, and then payment to manufacturers is tied to specific agreed upon outcomes. And then after these terms are negotiated, CMS's role largely turns to technical assistance and data collection, and there's also a federal funding opportunity that states can opt into. Next slide, please. So now getting into the meat of the program and the policy implications. Next slide. we'll have a timeline and kind of the model structure laid out here. You'll see that much has already happened since the announcement. So in the spring, states submitted letters of intent. A quick note here, these were non-binding letters and a letter was not required in order to participate in the model. So states are totally still able to decide if they want to submit an application. Also, this last spring, the sickle cell gene therapy manufacturers responded to a request for application, and from there, CMS and the manufacturers underwent a negotiation process on the key terms during the whole summer and fall. And then just last week, as we already heard, CMS announced that both Vertex and Bluebird, the two sickle cell gene therapy manufacturers, will be participating in the model. And those negotiated key terms have not been made public yet, but they have been disclosed to the states. So from here and through February 28th of 2025, CMS is now accepting applications from states and their responses to the funding opportunity. But states can choose to begin actual performance on the model anytime between January 1st, 2025 through January 1st of 2026. And again, CMS is doing that technical assistance and data collection throughout the lifespan of the model, with the model evaluation period ending in 2035. Next slide. Getting into some eligibility requirements for the different parties. I won't go through all of this, but a few things to highlight for states. Note that the fee-for-service beneficiaries must be covered by the beginning of the performance agreement, but states have until January 1st of 2026 to include managed care. It's also important to note that states must include CHIP as part of the Medicaid program. But inclusion of beneficiaries in separate standalone CHIP programs are optional. The manufacturer requirements are fairly straightforward. So market FDA approved therapy, obviously, and participate and enter into a negotiation agreement with CMS. And then beneficiaries, those who are deemed eligible for gene therapy based on clinical requirements, and there's also negotiated prior authorization criteria that goes into it. And then, of course, receive a drug under a Medicaid program or a CHIP. Next slide. So this and the next slide highlight the goals of the model, the potential benefits, as well as the potential challenges. These have been highlighted by the Sickle Cell Disease Partnership. So the primary goal of the program, obviously, is to secure access and follow outcomes, though I think it's also kind of a balancing act between capturing the potential for these new therapies while also addressing their costs and outcomes. The model also has the opportunity to ensure equitable access for the sickle cell gene therapies in Medicaid, which is incredibly important for sickle cell care more generally. Of course, there's the opportunity to reduce Medicaid expenditures, so leveraging the potential of the gene therapies and ability to participate in the model to effectuate longer-term healthcare savings. Another goal of the model and a potential benefit is to expand support services. So states who apply for the cooperative funding agreement will have some additional support to improve access to the therapies, but also to promote multidisciplinary comprehensive care in conjunction with the model. And I guess I haven't really mentioned that cooperative agreement. That is not competitive. All states that meet the requirements can receive up to, I believe it's about $9.5 million for implementation in different research projects. And on the manufacturer side, manufacturers will have certain anti-kickback requirements waived such that they can provide transportation and fertility preservation to the model participants. So all of that expanding the support services for Medicaid beneficiaries who undergo these treatments. There's also an opportunity for it to help create some consistency in access and to establish a more consistent Medicaid framework for those who choose to pursue gene therapy by addressing different imbalances between managed care, fee-for-service, out-of-state access, variation in coverage policies across states. So kind of just creating some consistency there. And also the lower administrative burden is important to know, as the burden on states to negotiate these, really complex clinical endpoints with manufacturers and to create robust data collection is significant. So by participating in the model, much of this burden is alleviated. Next slide, please. So here's some potential challenges, but really most important in encapsulating this entire slide is it's too early to draw any conclusions. We don't know how many states plan to participate and beneficiary interest in sickle cell therapies is still being determined. On that note, this is not an option for everyone. Not all individuals with sickle cell are eligible for gene therapy, nor want to undergo therapy, nor live in a state that that will participate in the model, right? So given these facts, the partnership finds it really important to continue addressing comprehensive care and treatment for everyone with sickle cell. There's also a substantial need for a wide range of inpatient, outpatient clinical services, which likely will not be covered by the cooperative funding agreement. So CMMI is largely deferring to states to provide adequate coverage for these types of services rather than using its own authority to ensure the coverage. That may work, but of course, these services are really needed for full success of gene therapies. There's also some public-private disparity between publicly and privately insured individuals, and that is largely given due to the startup time required for the model and the fact that not all states will participate in the model. So that drives differences between Medicaid beneficiaries. And also the anti-kickback statute makes it difficult for manufacturers to provide assistance for fertility preservation for publicly insured patients. Here, manufacturers, as currently proposed, can only provide these services to beneficiaries receiving treatment under the model. So that again creates a disparity between those who are in the model versus those who are out of the model. And finally, there are limitations in fertility preservation. So the access model doesn't enable participating manufacturers to cover IVF or storage fees for a long period of time. I believe the CMS requirement is somewhere between 5 to 15 years. So if an adolescent is receiving therapy, the cost burden for preservation will ultimately shift to the individual at some point. So again, emphasizing that the partnership sees the benefit of the access model, but also recognizes some of these continued challenges that, of course, CMS and all stakeholders will be continuing to figure out in the coming months and years. So we're looking forward to continuing to track that progress. And if we go to the next slide, I can open it up for any questions. Oh yeah, and also there's some resources on the next slide. I'm not totally sure if these slides are being circulated, but if they are, you can have easy access to some different CMS resources as well as partnership resources.
Thank you, Elizabeth, and thank you for those resources. We love resources around here, so we'll make sure that everyone does get access to it. And thank you for your presentation. We do have a couple questions for you in about 4 minutes to get through them, just so you know. So the first one is from Sonia, and the question is, for the data collection piece of the CMS access model, should that input be coordinated by the payer or directly from the provider?
Can you say that one more time?
Absolutely. For the data collection piece of the CMS access model, should that input be coordinated by the payer or directly from the provider?
So I believe I have a note on this. So manufacturers, if this answers your question, manufacturers will submit patient level. Well, do you have an echo there? I'm getting a bad echo on my end.
There was an echo, but I'm going to mute myself.
Okay. So I have no idea.
Try again.
They're working now.
Yeah, it sounds a lot better.
Yeah, I think I had the Zoom opened in a. Yep. Okay.
Okay.
So sorry about that. So through the model, manufacturers will submit patient level sales data to CMS and then cross-check against claims data of patients who receive the therapies. So CMS is really coordinating on that data collection piece.
Okay, great. And then one final question. What specific steps are being taken within the model to ensure equitable access to these therapies, especially in underserved communities?
So I think a lot of that is going to be largely state dependent on some of the terms that the states are able to negotiate with manufacturers, as well as whether states are applying for that cooperative agreement with CMS, which gives a little bit more funding to leverage to support those additional services that are needed for patients, to target patients in different areas and populations in the community.
And we did have one more question squeezed in, so I'll throw this one at you. Elizabeth, do you expect that the terms of the outcomes-based agreements will be released to the public?
Yes, I believe they are supposed to be. I'm not quite sure on when.
Okay, but if someone wanted to follow up with you on that, then they could do so.
Sure, I would have to double check on it.
Okay.
I was kind of working under the assumption that they were, but I could second guess myself there. So let me look into it as well.
Okay, wonderful. And thanks for the rapid fire, and really appreciate your time.
Thank you so much. Happy to be here.
All right. Next up, we have a presentation from Jimmy O'Leary, and he'll be talking to us about accessing new sickle cell therapies. So just a moment here. So Jimmy, a little bit about Jimmy. Jimmy is a gene therapy recipient who's developed a keen interest in the advancements of cell and gene therapies since his transformative participation in the groundbreaking clinical trial. He's passionate about the positive impact these therapies can have on patients in need and has become a staunch advocate for increased accessibility of gene therapies for SCD patients worldwide. So in this session, Jimmy will share his very personal journey of accessing the gene therapy and highlight some of the challenges, successes, and the impact that these treatments have had on his health and life. So with that, welcome, Jimmy, and please come off mute and say hello.
Hey everyone, it's good to be here. My name is Jimmy O'Hare. I had the good fortune of participating in a clinical trial that completely changed my life. And, I feel like a lot more people should have that same opportunity. For me, accessing or finding the clinical trial wasn't difficult, but I feel like I think it should have been easier. I did not get to the point I am at right now because my hematologist, brought this novel solution to me. I actually had to go seeking for it myself, which I was fortunate that I found it. Unbeknownst to me, there's this cell and gene therapy community that had been going on for about 3 to 5 years pre my transplant. And I had done some, living with sickle cell disease. It had become quite difficult to manage the disease. My quality of life was really poor. I had come many instances close to losing my life. So at this point, me, my parents, my family, were really, really just desperate to find anything that can improve my life. And I started doing some research on gene therapies and sickle cell disease. And probably a year or two after that research, I got an article in my inbox about a clinical trial that was happening in Nashville and this patient called Victoria Gray that had just gone through this fantastic process. And, I feel quite fortunate that I found that, but I feel that should not have been the case. So one of the things I did as soon as I contacted the team and they thankfully got back to me the next day, the first thing they asked me to do was to reach out to my hematologist. And, given that he's my hematologist, he'll have a better understanding of my history, my sickle cell history, and see if this might be a potential solution for me. And to my surprise, my hematologist had actually never even heard of it. And from my standpoint, it actually even seemed like he was pushing me away from potentially trying this clinical trial, telling me it's closed and I don't think he would qualify. Thankfully, we pushed forward and we continued to engage with the team that was running the clinical trial, and eventually I was able to get qualified for a transplant, and I could have potentially missed out on it if I listened to my hematologist that this was something that was not a fit for me. So I think that's one of the challenges that needs to be addressed. I think at least now, a lot of hematologists treating sickle cell disease know of gene therapies, but 5 years ago, I felt like my hematologist didn't know about it, and I was left wanting. And I can imagine other patients could have been in similar situations as me, where they are left to their own devices and left to take because they have no other options. I'm fortunate that I was able to do research and put Google alerts and do all these tech savvy things that some other people might not be able to do. And because I was able to do that, I was able to, move forward with this clinical trial. So I think that's one of the things that needs to be addressed, although I do think it has been addressed because, sickle cell is going through this moment now where gene therapies are almost like kind of a silver bullet. So I'll be surprised if there are hematologists out there treating sickle cell disease that haven't really heard of gene therapy. But at the time, my hematologist hasn't heard about it. So that's something that needs to be addressed as quickly as possible if it hasn't already, making sure there's as much information out there as quickly as possible about these gene therapies and how efficacious they can be. That's how I found, that was my personal experience getting to gene therapy. In terms of barriers of access, for me, I didn't face any, thankfully, because I got it through a clinical trial for free. Obviously, because it was a clinical trial and probably the first clinical trial, the second, things could have been, things are being improved up. Things could have been better, but like I always tend to say with clinical trials or things that are new, pioneers typically get slaughtered. So I felt that there was a bit of that, being that this clinical trial was one of the first of many. But from what I've seen them take feedback from what patients went through throughout the clinical trial process and improve it and deliver a much more efficient, painless patient process. But as we all know, gene therapies are inherently inaccessible. So I think that is where we need to focus our efforts on now, is on post-approval, making sure that these therapies are affordable to everyone that wants one. One of the first things that comes to mind when it comes to accessibility, particularly here in the US, excuse me, is really our healthcare system. I think that needs to be reformed, and I think we are taking a step in the right direction, particularly with CMS moving away from the traditional value-based pricing that we're kind of used to here in the US to something that's outcome-based. I think that's a fantastic step in the right direction, but it's just a step. As we heard from Elizabeth, there's still lots of work to do, particularly getting states to buy into this new model. And we can take historical lessons from states and the Affordable Care Act, and we see how that plays out. And I see that same scenario potentially happening here with patients on Medicaid that might want access to this treatment. So there's lots of work to still go on. I'm not sure I have the answers, but I think that's the fact that it is not value-based, because from the data we're seeing, the value is in fact there. And I actually have a serious worry with outcome-based as well, even though it's a step in the right direction. Based off the data that we're seeing, I believe patients are going to hit those benchmarks, health benchmarks, and more patients are going to be interested in partaking in, or patients that have severe sickle cell disease are going to be interested in moving forward with something as advanced as gene therapies when they see that it's actually working. I worry that's going to be a stress on the CMS system, but that remains to be seen. It's still quite early, but there's lots and lots of work to do there. In terms of my recommendation on how I think on how to just make these therapies accessible or more equitable for people living with sickle cell disease here or in the US, even here in the US in particular, I think it's really addressing the issue globally. For my gene therapy, one of the things that was extremely difficult was going through the collection process about 4 times. So I had to get mobilized 4 times, which isn't painful, but it's very uncomfortable, and no one really knows why. So I say that to say that we truly don't have genetic diversity to make these therapies, to understand why things happen, and we can potentially make these therapies even more efficacious if we give people at the root cause or the epicenter access to these therapies as well. So I think solving the issue globally through what we have now, while we keep an eye on the future through technologies like in vivo, I think ex vivo clinical trials should be on the continent of Africa and India, Asia, I should say. And we should enroll more patients. I know St. Jude is doing something fantastic where they're enrolling patients for clinical trials here in the US. We need to see more of that. I believe that is what's going to make the therapy more accessible, one, because we're going to understand it, and one, we're going to have so much more enrollments from people that live in Africa, which is the birthplace of humanity. So we're going to understand how to make it even more effective, thus lowering the cost. So that's my envision for gene therapies. I think it's just really global accessibility.
Thank you so much, Jimmy, just for highlighting what all of that was like for you, even some of the more painful moments. I just really, we really appreciate you walking us through that. We do have a couple questions and some that you may have touched on a little bit, but just to get a little bit more insight. what advice would you give to other patients navigating the healthcare system as it is, who are trying to pursue getting access to this therapy? Are there any resources specifically or support systems that you found helpful just as you were exploring that yourself?
Yeah, there are a number of support systems I had. I was fortunate enough to be connected to a few participants, early participants of gene therapy, really hearing their experience. I think that really gave me confidence that although this might be scary, the conditioning, chemotherapy, blah, 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 all of that scary stuff, hearing it come firsthand from someone that's just gone through it and looking fantastic, might I add, was immensely confidence building for me to move forward with the clinical trial. So I think that's probably my first suggestion, is probably trying to, and I don't think that's a hard thing in this day and age, because so many of us have come public with going through gene therapies, that you can easily find someone that's gone through a gene therapy and really let you understand from collection all the way to infusion what everything would look like. That, I believe, is probably the most important thing, because I think gene therapies are still, in a way, kind of mystified and scary and cumbersome and all these huge scary words that rightfully can potentially push patients away. But if they see someone that literally has exactly the same disease that they have, doing really well and explaining, despite how heavy and big and scary everything may seem, it's actually quite a simple process from start to finish, although it might be long.
Yeah, and I think that's why your advocacy is so important, and you're doing the same thing yourself in terms of demystifying and pulling back the curtain on what it was like and what that looked like for you. So just a little bit more on what it does look like for you. I guess, are there any changes or specific improvements that you've noticed sort of just in your daily life since having the gene therapy? And just what, I guess, what do your days look like now, being on the other side of it that you could share?
Absolutely. I mean, the changes have been 180 degree. They've been almost detrimental, because in my opinion, I don't think everyone is going to have this experience, but I think it's just who I am as a person. I think I actually changed too fast because of the gene therapy, or because of my wanting to change from living with sickle cell for so long, that, and I had the ability and capability to, because the gene therapy, the one I went through at least, had been so effective. My days are completely different, than what it used to be. Like, I'll give you the best example I can. There was a time in my life where from sun up to sundown, I was in bed, particularly in the winters when I lived in New Jersey, because typically it was cold there. And I would stay, my wife would wake up at 7 a.m. to go to work, and she would literally leave for work at 7 a.m. and come back at 7 p.m. and I would still be in the same spot in bed when she came back from work. And fast forward to getting this gene therapy in September, I was able to summit Kilimanjaro. That's how vastly different my life has become.
Yeah, that's a big difference. And I saw the pictures as well. So congrats to you on that feat. But you're right, and also sharing that the changes that people experience, it will differ person to person. But just in you and your experience, that's really great to hear. I'll just see if we have any more questions. And it looks like we don't. But thank you so much again, Jimmy, for sharing and being here with us today. And we will go ahead and move into our next speaker. Okay, so next up we have Nikki Braccio, who's here from the Center for Medicare and Medicaid Services Innovation Center. A little bit about Nikki. So Nikki serves as the learning system lead for the Cell and Gene Therapy Access Model for CMMI. And in this role, Nikki designs and implements learning communities to support model participants and partners with improving equitable access to cell and gene therapies for people living with sickle cell disease. Prior to joining CMS, Nikki served as the policy director for the National Patient Advocate Foundation, and before that, advised life science clients with coverage and access policies at Avalier Health. Nikki began her career as a pharmacist in the community setting, practicing in New York and New Jersey, and she earned her Doctor of Pharmacy degree from Rutgers. And so in this session, Nikki will explore the cross-model learning system within the CMS Innovation Center's cell and gene therapy model, highlighting how collaborative networks and shared knowledge are driving the successful implementation and expansion of gene therapies for sickle cell disease. So with that, Nikki, I will pass over to you.
Great, thank you so much. And can you hear me okay?
Yes, we can.
Great. Right, well, as I serve as the learning system lead for the CGT Access Model, I sit in the Learning and Diffusion group at CMMI. In LDG, we design and carry out a broad set of activities from peer learning to data analysis and engaging with the healthcare community. And all of this is aimed at achieving swift and widespread adoption of effective payment and delivery models that can potentially decrease health disparities and result in better health outcomes and the patient experience for all Americans. It is such a privilege to be with you here today and to partner with Sickcells on building a learning system that reflects what is important to the sickle cell disease community. Next slide, please. Okay, one more. Thank you. For this model to be successful, we recognize that it is critically important to partner with participants on implementation and learning of what works and what doesn't work in the model. We also acknowledge that to accelerate implementation, we'll need to provide key resources, assistance, and ongoing support to model participants. And we look to those participants to co-create what that looks like. As Aurelia mentioned during the keynote, we have a lot to learn. And in this early phase of pre-implementation, as well as throughout the model lifecycle. So just to pick up on what she shared earlier, that could look like how can we encourage state participation in the model, uncover any roadblocks that states may have in participating and resolving any technical issues. And we see the model as being a vehicle to foster relationships between states and the sickle cell disease community. So it's great to hear about all of the current and ongoing conversations that are happening through this summit, as well as in other settings. All of this and more, we hope to address with the CGT Access Model Learning System. Next slide, please. Okay, so what is the learning system? It's a vehicle for diffusing and spreading what works well for participants to achieve the model aim across the network of participants and partners. That includes our state Medicaid agencies, providers and care teams at sickle cell disease treatment centers, and last but not least, community-based organizations. The learning system will do a number of things. First, it will be data-driven and leverage what we learn from participants and partners to feed back into our system. It will create and maintain a collaboration platform for peer sharing and accessing resources, provide opportunities for peer-to-peer learning, and disseminate best practices, actionable resources, and learning tools based on what participants say they need. Finally, we will identify innovations that are associated with success and share this throughout the learning system. That's sort of the bigger picture. Next slide, please. And specifically for CGT, our goal is to capture best practices for increasing equitable access to cell and gene therapies and improve outcomes for people living with sickle cell disease, and then facilitate integrating these best practices across participating states nationwide. Peer-to-peer learning is a critical component. We will work with participants to offer case studies, toolkits, and tip sheets, as well as opportunities to join or provide opportunities to join nationwide webinars and more intimate affinity groups to connect with one another, problem solve, and share what's working. And that leads us to the infrastructure that we're currently building. That includes a virtual platform for disseminating information. And we're working closely with the CGT model team to develop other mechanisms for collaboration and communication as well. Next slide. So our approach to learning in the CGT Access model aims to build bridges between participants and partnering organizations. I've heard a lot so far about the ongoing collaboration and whether it's at or through the Centers of Excellence, through nonprofit organizations like Sickle. And this is certainly something we want to build upon because we know that none of these, for the model to be successful, none of these things should be happening in silos. So we're envisioning 3 learning communities. The first is focused on state Medicaid agencies. The second is providers and care teams at sickle cell disease treatment centers. And the third is community-based organizations. So our team will support members in each of the communities to address the specific needs within states, within the provider community, and within CBOs, but also to address, we expect that the communities will intersect each other and feed back to CMS to inform how the model is working. And just a few topics for each of the communities and their specific needs that may include ensuring equitable access to gene therapies, whether through the drafting of coverage policies or assessing whether access is happening equitably. Also, a big part of this will be addressing health-related social needs, which we know can happen at the treatment center level, as well as the community-based organizations who provide much-needed services, such as child care, transportation assistance, and the like. And lastly, we expect that care delivery and workflows may need to evolve and adapt to the changes in increased demands for gene therapies over time. And as we think further out into the future, as this model could potentially cover other conditions, we want to really use and leverage what we learned here with the sickle cell disease community in care delivery to promote optimal workflows and care delivery improvements. We also expect, and just to kind of make a finer point on how the communities may intersect each other, one example is that a question that we're thinking through as we're building this learning system is, how can CBOs partnering with states best help patients overcome barriers to care that is provided at treatment centers? And there's a number of avenues and mechanisms for addressing health-related social needs. Some are within the existing Medicaid program, whereas others are external and building off of the community engagement and services that are being offered outside of the Medicaid program. Another question that we have is around the type of collaboration between providers and community-based organizations. This would be helpful to ensure that as we're thinking through patients' holistic needs are being met. So definitely want to see some cross-pollination of best practices between treatment centers and CBOs. And then one other example is around what are providers at treatment centers hearing from patients and caregivers about the experience receiving gene therapy in their state. So this is I think, a crucial role that our patient advocates here today can play. I know you have been incredibly gracious with advocating on behalf of the sickle cell disease community, and this input is extremely helpful to determining what kind of care delivery changes may or may not need to happen to make gene therapy equitably accessible. Next slide, please. Okay, and as Aurelia mentioned in the keynote, states that are interested in participating can apply by that February 28th deadline, as well as for the optional funding opportunity. And I'll just point out and reiterate here that this funding can be used for states to partner with CBOs, treatment centers, and/or academic institutions. So we see treatment centers and CBOs as playing a key role in model success. And the way, even just by virtue of the way you represent your unique communities within your state is invaluable. Even at the more local level, I know Tristan earlier made a great point about being able to access certain clinic settings that might be over 2 hours away. So knowing the specific challenges within communities geographically will also help us figure out how we can make this work best. So for all of the sickle cell disease warriors and your families out there, I thank you for using your voice to advocate for your community. And we encourage you to build those relationships with staff at your state Medicaid agencies, as well as encourage you to continue having conversations with your care teams about the potential of gene therapy in sickle cell disease and providing feedback to your care team about your experience receiving care. So I know my presentation is rather short because we are still very much in the building phase of our learning system. And given the rolling start for states throughout 2025, we do have some time to shape and craft this learning system in the way that's going to best meet the needs of our participants and partnering organizations. So I'm happy to answer any questions, but I also have a couple of questions for the group. If you wouldn't mind, feel free to reply in the Q&A with any feedback, but I'll pause first, see if there's any thoughts.
Thank you, Nikki. We certainly do have a number of questions for you, and we'll keep an eye on the Q&A in the chat to see what comes through further. So one question is, are there specific equity metrics that CMS is paying attention to, and are they available online?
That's a great question. And I would say that's better suited to be answered by our model design lead. But I do know that this model was created with equity in mind, and I think more information will become available as the model launches, as far as metrics and other specifics. But if there are metrics that Anna, you would like to draw attention to, I would be happy to take a look and just kind of see how that might play into the learning system.
Thanks. And there are more questions about metrics, but you may have a similar answer. So one is also just about how the impact of this learning system will be evaluated and what metrics will be used to measure engagement, if there's anything that you know right now or are planning to build into the model.
Yeah, I think the metrics will, and this is sort of the classic, implementation science, and the learning system will be measured according to measures that both come from the model design as well as engagements. So thinking about, because this is the first learning community is dedicated to states, we want to see as much participation in the learning system as possible, and we'll be tracking engagement in terms of participation in certain convenings and engagement in materials that are shared by peers. We'll also be looking to support any ongoing conversations between states and make resources available that a state might want to share with the network. And then similarly, we'll be looking at engagement metrics for the both provider and CBO communities. But I think it's actually really exciting that we're in this early stage because we want to track and look at what is important to each of those distinct communities. So TBD, but again, really appreciate any thoughts or feedback as far as what success would look like for you as a state participating in a community, as well as our CBOs and providers.
Awesome. And then just one final question that's come in so far, sort of touching on your comment that Tristan made about how there are some, centers and resources that are just sort of too far away. And so the question is, how does the cross-model learning system help build capacity in regions with limited expertise or resources, ensuring that there's more equitable access to these therapies?
Sure. Yeah. So great question, and I didn't mention it earlier because when we think about a consolidated learning system or a cross-model learning system, we in LDG have the benefit of working across models. So in the partners that we work with to execute on the learning system, we are also working with Medicaid experts and clinical experts, as well as supporting the two other models at CMMI, which have been announced and will launch in the coming years. So the first one is the Transforming Maternal Health model. So we do see some synergies there with, especially looking at the patient care journey around and conversations around fertility preservation, and what we can learn from the maternal health experts about considerations to think through for learning. Similarly, and this was pointed out, I think earlier as well, there is definitely an intersection between behavioral health services and supports and the patient care journey in CGT. We know that this is a long and grueling road, whether you're receiving the gene therapy or not, and oftentimes behavioral health is left out of the coordination, but we want to make sure that we are thinking and integrating behavioral health as best as possible. And so one way that we can leverage other learnings within CMMI is through the innovation and behavioral health model. So that is another model that involves providers in accessing or providing behavioral health to those model beneficiaries. So that model will cover a distinct set of states that we can leverage and think about, what's working well in connecting behavioral health specialists with other specialists, such as hematologists or primary care providers. So I think it is exciting to be able to kind of put all of these threads together and really make efficient use of our learning systems and the team here at CMMI.
Very exciting, very exciting. Thank you so much, Nikki. I didn't see that we had any more questions come through, but I'm sure people will have a number of questions for you after this presentation. So thank you so much for your time.
Yes, and Kelly, if I may, there are two questions that I would like to pose to the audience, and if folks have thoughts or ideas, would love to hear that, especially knowing that there are state Medicaid agency representatives in the room, as well as CBOs and patients. So the first one is, what do you think will be important for us to continue to think about as we build the learning system in the coming months? And then are there topics or priority areas you consider critical for participants and their partners to learn about to support this model's success? I know we had several overviews of the model earlier today. And again, learning is very much a rapid cycle, more real-time look at how the model is operating. So building the system and making sure we're addressing the needs of each of those communities will be really important. So any ideas on what other things we should be thinking about, or things that I didn't cover that you would like to see? Can't make any promises, but definitely we're committed to partnering with all of you and look forward to hearing any thoughts.
Wonderful. And just so everyone knows, we did just open the chat so that you're actually able to respond to Nikki's question. So you should be able to use that function now if you do have a response.
Great. Thank you so much, and appreciate you inviting me here. It's definitely a privilege to be here, so thank you.
We'll just give it a couple minutes. Okay. Oh, wait. Okay, I think we've had, okay, yes. Can you see that, Nikki, in the chat? The response?
Yes, I can. Thank you, Stephanie. One of the things that is paramount in understanding is the amount of expertise that we as patients have with this being a genetic illness. Yes, could not agree more. So let's see, another piece is continue to build your model with the idea of addressing social determinants of health as barriers. And I'm sure Aurelia can attest to the fact that equity and addressing social needs and determinants of health has been paramount to this conversation, as well as what we hope to achieve through the learning system. Good call out. Yep. Another good point from Stephanie about patients having to have the onus on educating doctors, staff, and we are very capable of sitting at this table as individual patients. Absolutely. At National Patient Advocate Foundation, we would always say perspectives and goals about what matters to you in receiving care is clinically relevant information. So definitely rings true here as well. Right, well, really appreciate the engagement. And thanks again, Kelly.
Yes, thank you again, Nikki. And for everyone, we're about to move into a 10-minute break. So we will get into that and be back here at, what's that? 2:10 Central, but 3:10 Eastern. So yes, thank you very much and see you soon. All right, we're gonna go ahead and get started. And this is our final speaker session of the day. So we hope you've enjoyed everything so far. But last but certainly not least, we have this super dynamic group of ladies who are going to talk more about the critical role of community-based organizations in sickle cell. And so just to give you a flavor for what overall these sessions will cover. So we're going to be exploring the role of CBOs in navigating the complex landscape of coverage gaps in SCD healthcare. We'll gain insights into how CBOs are already addressing disparities in access, advocating for patients, and driving innovation on a local and national level. And the discussion will highlight successful strategies that they've used to bridge gaps in insurance coverage and enhance patient outcomes through community-centered solutions. And so we are going to start first with Linda. And a little bit about Linda. Linda is the president and CEO of the Sickle Cell Association of Texas, the Mark Thomas Foundation. She has dedicated her career to advocating for individuals with sickle cell, focusing on providing support, education, and resources to patients and their families across the great state of Texas. So Linda, we're just getting your slides up, and then you will be able to come on and introduce yourself and get going. All right, and we're ready. Linda, please go ahead.
Good afternoon. I'm Linda Thomas Wade, president of the Sickle Cell Association of Texas, Mark Thomas Foundation, where we've been serving families with hope and integrity since 1997. Next slide, please. A brief history of our organization. The organization started in 1997 by myself and my wonderful husband, who wanted to advocate for families suffering from sickle cell disease. My late husband, the late great pastor, Mark Thomas, even though he lived with sickle cell disease, suffered from pulmonary hypertension, congestive heart failure, and wore oxygen 24 hours a day, he was a great champion for families living with sickle cell disease. We were married for 27 wonderful years. Unfortunately, he passed away from sickle cell disease at the age of 46, but we continue his legacy and his mission. Next slide, please. We serve more than 1,000 clients and families. We provide certified case management, medical case management, referrals, SSI, SSDI assistance, housing, transportation, counseling, transition services, care coordination, medical home placements, scholarship programs, and limited financial assistance. We also have Camp Celebration, which is for our younger kids ages 6 to 14. And then we have Camp Next Level for our older kids transitioning from pediatric to adult care, as well as an escape, and that is for our adult programming. We offer support group meetings, and we used to offer free sickle cell trait testing. However, due to costs, we're no longer able to offer that free service. We also have empowerment conferences, walks, and many other events. Next screen, please. One of our accomplishments is we had a listening session with Admiral Levine, where we were able to bring our families living with sickle cell disease so they could really share their story and their different, and we had them from all different walks of life, from doctors living with sickle cell disease to students, to parents who no longer have their children. But it was a wonderful event, and we were very grateful that Admiral Levine chose our organization to come to. Next slide. Just a few of our past accomplishments. We were able to successfully lobby to have all newborns tested for sickle cell trait, because here in the state of Texas, all those babies born with the disease were notified. However, those that had trait were not. And we have a huge newborn screening trait population. We were also able to serve under the former President George W. Bush, where I was appointed as a United States Health and Human Services Advisor on blood safety and availability. And I'm really proud as well to say that we were, as far as I know, the only CBO that was invited to meet with President Barack Obama in the Oval Office in his first 100 days in office, something that we're still very proud of. Next slide, please. We also were selected to do Faces of Sickle Cell, and we were very grateful to do that for NIH. Next slide, please. With our topic today, I will be very short, but prayerfully very clear, because it is very important for everyone to know that the community-based organizations are vital. We are the key to the sickle cell community. One reason is due to the discrimination warriors often face in medical facilities. Individuals and families living with sickle cell disease are not always receptive to what healthcare providers say or think. Therefore, these individuals often and truly do rely on and depend on the CBOs, because they know we're going to be truthful, we're going to be forthright, and we're going to be knowledgeable to help them make informed decisions, because they can trust that the CBOs have their best interests at heart. Now, our agency has had 3 individuals in the state of Texas that have gone through clinical trials. Based on their experience, we know that individuals and families who receive treatment and therapies will need long-term care, not just for the individual, but for the entire family, because of the long-term impact it can have physically as well as mentally. Next slide, please. So, the wraparound services that we have provided and can provide for therapies and treatment for non-medical costs include relieving stress and financial burden from loss of work and school, childcare for adults who are going through gene therapy, and adults who have other children needing support. We take a holistic approach where we work with the entire family. Transportation is also an issue. Meals, mental health support. Our social workers often help navigate families through that insurance process. CBOs can serve as a connection with the client as well as the providers. Respite, a caregiver and family member who is there with their loved one. It can be for several months after therapy. Respite could include allowing the caregiver or family member to get a break months after therapy. It could also provide peers who can help them navigate through the process. So what we have done was, when one of our kids or young adults have gone through or want to go through therapy, we connect them with someone that has done it. And I believe Jimmy spoke about that in one of the earlier sessions. And so that's why it's important to connect people to other people who have lived experience through therapy and treatments. Next slide, please. Now, there are challenges to gene therapy, and I would just like to mention a few. Affordability. Is it accessible? And does it work? And realistic expectations, because we have seen where individuals may have felt that once they went through the process, that everything would be fine and they would just go on their merry way. And unfortunately, that is not always the case. And I just really wanted to kind of stress that point. Last slide. So I think not only does the Mark Thomas feel this way, but I think other CBOs does as well. And I just had to put this slide up with our frogs to say, Mark Thomas and the CBOs, we are going to hang in there until there is a universal cure. Thank you so much, and God bless.
Thank you so much, Linda. These frogs are so cute and the perfect way to wrap up your part of the presentation. Thank you so much. And we're going to come back to you and everyone in the end for Q&A with the group. But for now, we are going to switch over to Tabitha, who's coming to us from the Sickle Cell Foundation of Georgia. So Tabitha is the executive director, where she leads initiatives to improve the quality of life for individuals with sickle cell disease. She has spearheaded several key projects, including the grand opening of the Sickle Cell Sanctuary, a holistic wellness center providing comprehensive care for sickle cell patients. With a background in leadership and community service, she is a passionate advocate for expanding healthcare access and supporting those impacted by the disease. So with that, Tabitha, please take it away. We can't hear you, so come off mute, please.
I am off of mute. Thank you so much, Ariel. And thank you, Linda. Your presentation was so wonderful. I really appreciate you talking about all that we do here as community-based organizations. So I want to take a different approach today. And first, I want to tell you guys a little bit about the organization. So the Sickle Cell Foundation of Georgia was founded in 1971 by two African-American Atlanta physicians that saw that there were children that were being born with some issues, and no one really understood what those issues were. But after they partnered, they realized it was sickle cell disease. Hence, they started an organization at 2391 right here in Southwest Atlanta. And so we're kind of the hub inside of Georgia. Next slide, please. I'm sorry, I just have a problem here. Something has happened. Okay. So the Sickle Cell Foundation of Georgia has implemented several successful strategies to bridge the insurance coverage gaps and enhance patient outcomes through community-centered solutions. And so we're going to talk about some of our key approaches today. Next slide. Patient navigation advocacy. So we have community health workers that guide individuals with sickle cell disease through the complex healthcare systems. Our CHWs assist with insurance enrollment, claim processing, appointment scheduling, and seek proactive care in the first and only holistic wellness center for sickle cell disease in the country. Advocacy for coverage. The foundation actively advocates with insurance companies to ensure coverage for essential treatments and medications. We work to address denials and appeals to secure necessary care. This is very critical because here in South Atlanta, many of our larger hospitals did close up. The Atlanta Medical Center downtown in Atlanta, as well as Wellstar, creating a huge need for additional coverage for our sickle cell disease individuals. We now create a financial assistance program. So we help patients access financial assistance programs, including Medicaid, Medicare, and private insurance subsidies. They provide guidance on eligibility. Next slide. Community education empowerment. So we provide regular workshops and health fairs to educate the community about sickle cell disease, its symptoms, and management strategies. Inside of our education workshop, we also have hemoglobinopathy. So we provide counseling to individuals who we receive the results from newborn screenings every Monday. And so our hemoglobinopathy counselors, they call the parents and let them know what those results are and exactly what does it mean when a child has sickle cell trait. We empower our patients. The foundation empowers the patients to advocate for themselves by providing them with information about their rights and how to communicate effectively with healthcare providers as well as state legislators. We have support groups. We provide support groups for patients and families to share their experiences, coping strategies, and emotional support. We have 3 psychiatrists that work here at the Sickle Cell Sanctuary, providing mental health support not only for individuals, but also for families as well. Next slide. Collaboration with healthcare providers. We have very strong relationships with our healthcare providers to ensure coordinated and comprehensive care for our sickle cell warriors. And this is very important because we want to ensure that the sickle cell warrior understands their disease. They also understand what their decisions are. And so we make sure that they're well informed to make a very concentrated effort in whatever decision they want as it relates to their care. And so by educating our doctors, we want to make sure that the doctors understand all the therapies that are available for our sickle cell warriors, so that when our sickle cell warriors inquire about it, our doctors have the knowledge to share with them about what it is that they want, or how they want to be treated. So shared decision-making. The foundation encourages shared decision-making between patients and providers to develop personalized treatment plans. Prompting early intervention. We promote early diagnosis and intervention to prevent complications and improve long-term outcomes. We believe that proactive care is more important than reactive care. Next slide. Research and innovation. We support research and initiatives to advance the understanding and treatment of sickle cell disease. The foundation encourages participation in clinical trials to access innovative therapies and contribute to medical advancements. We do not lean on any side of a particular clinical trial, but again, we make sure that our sickle cell warriors are educated so they can make an informed decision about which clinical trial they would like to try. Next slide. Community partnerships. We partner with other community organizations to leverage resources and expand our reach. What I'm really excited about, there are so many other community-based organizations around the United States, and we work together collaboratively. We share our resources. We want to make sure that our sickle cell warrior, no matter where they are, no matter where they're going off to college, that they are covered by another community-based organization. So by all of us collaborating and working together, it makes for a real whole experience for our sickle cell warriors. Building community coalitions. The foundation, we work with community leaders, policymakers, healthcare providers to address the needs of the sickle cell community. And again, there are so many various needs of our warriors. So we want to make sure that we're talking to the policymakers. We want to make sure that we're talking to each other. We want to make sure that we're talking to anyone that can make an informed decision about sickle cell disease. Next slide. So in conclusion, by implementing these strategies, the Sickle Cell Foundation of Georgia has made a significant impact on the lives of individuals living with sickle cell disease in Georgia. Our community-centered approach has helped to bridge insurance coverage gaps, enhance patient outcomes, and improve the overall quality of life for those affected by chronic disease. So thank you so much for giving me this opportunity to speak today. I really am in favor of us making some great decisions as it relates to sickle cell disease.
Wonderful. Thank you so much, Tabitha.
Welcome.
And a reminder that we will still have some questions once we wrap up with Ginger. And just a reminder to the audience as well, if you do have any questions, please get them in. Ginger Davis. So a little bit about Ginger. Ginger is the president of the Sickle Cell Thalassemia Patients Network in New York, and I recently had the privilege of visiting Ginger in her office. And Ginger is a longstanding advocate in the sickle cell community with over 25 years of experience in health education and advocacy. She focuses on raising awareness and improving access to care for those living with sickle cell disease. So Ginger, if you are ready, please come off mute and share with the team.
Yes, good. Good afternoon, everyone, and hello. As you can see, I'm still at ASH, and so I'll be leaving here this evening. But I'm very proud and excited to be sharing information about sickle cell disease in New York State, in our genetic region, also the U.S. Virgin Islands. And I'll get started with talking about, if we go to the next slide, talking about the demographics in New York State. So we have estimated we have between 12 and 14,000 New Yorkers, which we include, we're considered undocumented people as well. There are a lot throughout our state. Most of the population for sickle cell reside within the Metro New York area and the 5 boroughs, with the largest population in Brooklyn and the second largest population in the Bronx. And okay, I'm sorry, go to advance to the next slide. That's the introduction. Okay, great. All right, so most of the largest population is Brooklyn, and is mostly an immigrant population, both Caribbean, Latino, and African. And our numbers are growing steadily, not only in the 5 boroughs, but throughout New York State. Next slide. So our healthcare resources, most are attributed to pediatric population. In between 1990s and the early 2000s, our adult comprehensive programs were systematically being closed. We are down to the 5 adult treatment services in these hospitals: New York City Health and Hospital Corporation at Kings County Hospital, New York Presbyterian Brooklyn Methodist, Interfaith Medical Center, Florida One Brooklyn Health, Columbia University, and Mount Sinai. The gaps in care, mainly because we do not have adult programs to transition our young adults into, I'm jumping ahead of myself a little bit, but the gaps in coverage are happening mostly in the adult population. The most underrepresented populations that we have in New York State are in Long Island and Nassau and Suffolk County, and also in counties upstate New York. SCTP has identified populations in Westchester, Rochester, Buffalo, and Albany. And in other counties outside of those, we're finding one individual in a town. And most people don't realize that New York is a large state. So when we're seeing these one-ofs in particular counties, the next nearest county where there is actually pediatric or adult comprehensive care could be 1.5 to 2 hours or more away. The SCD population receives comprehensive care until the age of 21, and then after that, our young adults fall into an abyss of no care. With no qualified hematologist, no comprehensive program, no standalone clinics, the emergency department becomes the source of primary care for most of the adults in the state. And that includes in the city where our largest population is. So we have been seeing significant onset of complications and deaths in our young adults between the ages of 19 and 30 for treatable complications. And just because either the hospitals in the counties where they live don't know about sickle cell, or have on occasion refused to treat them. So what we find residents doing are driving 2 to 3 hours from upstate in different counties. If they're mid-state, they're going to Rochester, where they know that they can receive adult care, or they're driving into Westchester and the Bronx to get care, putting themselves at risk. If you're dealing with a complication like splenic sequestration or acute, aplastic anemia, that is not something that you can drive 2 or 3 hours to try to find care to address. So although we have not gotten any data that people have actually passed away in this journey to find health care, we know that it is a serious thing that needs to be addressed in New York State. The role of our community organization throughout the state and in the Virgin Islands is to provide program and services for transitions from pediatrics into adult medical care, to provide care coordinations and physician referrals, also to connect adults with a medical home, to do education and advocacy and social supports for individuals living with sickle cell disease, their caregivers and family members, also to providers and the general public. SCTPN began educating our community, and not just in New York, but globally, about clinical trials in 2017. We wanted people to understand what clinical trials were, the 4 stages of the clinical trials, the importance of us participating in clinical trials and staying all the way through. And now, I think since last year, we have begun educating healthy people in our community for the need to have healthy participants in stage 1 trials. And lastly, we connect our communities with critical healthcare services and other resources. We have a lot of housing insufficiency. We have people who are having issues with work-related incident and education. And so whatever the need that is brought to us, whatever arises, we try to answer to that need. And we'll go on to the next slide. I'm sorry, I forgot to tell you the advance. Okay, we'll go on to the next slide. Okay, so identifying collaborative solutions. SCTPN, the DNA of our organization is to collaborate. And we look for every opportunity to be able to collaborate not only with other community-based organizations, but with healthcare systems, healthcare administrators, agencies, legislators, and even concerned individuals who want to give support to our organization. We're not connected currently to the New York State Department of Health or to the Medicaid programs. We have been in the past, but we're seeing that turnover in staff and some other issues have been a barrier to our ongoing relationship, and especially when it comes to getting data, the needed data that we need to be able to locate the population that we need to serve and to report, particularly to funders and other things. So we're absolutely looking for the opportunity to reconnect with the Department of Health and with the Medicaid department so that we can start planning and actually being able to be more effective in the services and the programs that we deliver to our community. So we absolutely give an open welcome to anyone who wants to collaborate with this organization. So you can see this is an image of the affiliates and chapter that we have under our umbrella organization throughout the state, and our international affiliates in Uganda, Belize, and Gambia. We're going to be welcoming Tanzania in this month, and some of our other community hospitals, both hospitals, other community-based CBOs, and some of our international partners like in the US where. Okay, and I think there was one more picture. So I also want to speak about, the power, just very briefly, the power of the CBOs. And we saw that picture with HHS, with Ashley there speaking, and for Secretary Becerra to begin doing these HHS programs for sickle cell speaks to the power of the CBO and sickle cell. Thank you.
All right, trying again. Oh. All right, try. So sorry. Okay. All right, now I think we've got those audio issues fixed. Sorry about that, everyone. Thank you, Ginger. And I really wanted to just pick up on your last point about the power of CBOs. And so I do have, we have time for at least a couple questions for the group that I'll pose. But I really want to talk about the power of CBOs as it relates to policy and advocacy and policy work. And so the question is, what role do CBOs play in advocating for policy changes or collaborating with healthcare providers and payers to ensure equitable access to care for sickle cell disease patients? And what is our superpower there, I suppose? And I think Ginger, you're speaking, but you're on mute.
I'm going to start with the superpower, what our superpower is. I believe our superpower, many of our organizations are started by people either living with sickle cell disease or caregivers of people with sickle cell disease. So we have, we're subject matter experts and we have lived experience. So we can say, honestly, from our own life lived experience, what it is that we need, what our families need, and what our community needs. We are able to, I guess, not only talk about, the psychosocial issue and how it affects us, but also talk about the economic aspect of it. Most families with sickle cell disease are living below the national poverty level, subsisting on government subsidies, and it's not a good feeling. And you have people who die and their families don't have money to bury them because we're not allowed to even have a savings. So there are issues, I think, beyond just dealing with treatment and research that also has to be considered by government. So for us to, we've been teaching people how to advocate and educate politically with their legislators, and from municipal, state, and federal legislators, what it is the community needs besides just healthcare. And some of the policies, like for instance, the booklet that happened with Social Security around sickle cell. And I think that's wonderful. But then I asked the director, how is that going to impact people who are on the new disease modifying medications or therapies where their hemoglobins are no longer going to be at a 7? They're going to be at 10 and 11 and 12. Is that going to impact on somebody applying for Social Security benefits? Those things have to be considered because, it's hard for healthy people really to understand how we're affected and where this technology is taking our care right now. So, and it was like a oops moment for them. And they're like, can we just enjoy this? I'm like, enjoy the day, but we're going to have this conversation. And that's coming from the CBOs because many individuals living with sickle cell disease and their family can't speak because they're so emotionally and mentally impacted by the pain, by healthcare disparities, and by the death that shouldn't be happening in this day and age. So CBOs really need, these are people who are willing to speak up and willing to take on the pressure and the fight. And I can't say enough about what our power is in terms of representing our entire population. And we just don't look at our city or our state. We look at it nationally, we look at it internationally. And that is the power of the CBOs.
And as it relates to helping with policymakers, we do help form policies by working with our lobbyists and working with the members inside of the state capitol here in Georgia. And so oftentimes after listening to our warriors and understanding what they need, we will present those bills to our representatives and carry a bill through and try to get it approved. And so as Dr. Davis was saying, it is critical for community-based organizations to be involved in this entire process because number one, our sickle cell warriors trust us. Number two, we have been around, for well over 40, 50 years, many of us. And so they understand that we've learned how to navigate the systems. We've learned how to navigate, healthcare. We've learned how to navigate the policies. However, it's still not enough done. When I look at my notes, we go back to 1904 when sickle cell disease was first discovered, so to speak. And here it is, we're now in 2024, and we still only had a handful of therapies that really, quite honestly, today are not working. And so we have a lot of people that's in pain. And if you could just imagine having a toothache for a couple of days or a couple of hours, it's very painful. And unfortunately, sickle cell doesn't have a look. You can't look at an individual and tell how sick they are, because outside, externally, they look perfectly fine. They're like everyday normal people. But internally, if you had a microscope and you can see the damage that was done to all of their major organs, then it paints a different picture. And so we definitely need help inside of our community. All of us as community-based organizations have linked together, partnered together, resourced together, but we need more from the upper echelons in the world, so to speak, that are making decisions, that have the monies to actually help us help our people.
Absolutely. And Linda, did you want to add to that as well?
Yeah, I just wanted to say that I totally agree with everything Dr. Davis and Tabitha has shared. And it's really sad that the CBOs, not even only the CBOs, but in certain pockets, especially here in the state of Texas, including one of our doctors living with sickle cell disease, that they are being denied care, or they're being extended out for so long, like a year. We're gonna see you in a year. And it is a upward battle and fight. So I do believe that, number one, the CBOs, we do have great power, but we do need those that are in power to work with us to get access to care for all individuals living with sickle cell disease. Because it is really sad that with certain chronic illnesses, there's so much access. And then with sickle cell disease, that huge biases and discrimination. And to be honest, we have lost quite a few of our transitioning kids because of that lack of care. So I just wanted to say that I definitely agreed with everything they had shared, and I just wanted to share that information as well.
Yes, thank you all so much for that. And I'm sure we can all on the call agree with those sentiments. I do think we have time for one more question before we are closing out with Ashley. And similar to a question that was asked earlier in today's session about future hope. And, and again, the role that CBOs will be playing in shaping the future of how everything from education to care to transitions in care. I'd really love for us all to hear from you three on what your ambitions are and would be.
Well, certainly there's absolutely a lot of hope. Our sickle cell warriors are resilient. Our sickle cell warriors are successful. Our sickle cell warriors have their own businesses. We have doctors with sickle cell disease. We have attorneys with sickle cell disease. We have individuals that are living well with sickle cell disease. However, there's still a lot of work that needs to be done inside of sickle cell in itself. The healthcare providers, the nurses, the lack of sensitivity, the lack of compassion and empathy for individuals that are suffering on a day-to-day basis. We have to remember they did not ask for the disease. It's not contagious. You can't catch it. You're born with it. And it's a chronic, painful disease. And so to be left in the emergency room for hours without being triaged, to be left in a hospital room in the very cold without additional blankets on, we know that people need to pay attention and wake up. This disease has been around for a very, very, very long time, and it's enough have not been done to support our warriors, our sickle cell disease. And so we want to make sure that there is hope in every heartbeat. Every heartbeat, there is hope. Our sickle cell warriors have not given up. They fight to the very bitter end, and they're still fighting. And guess what? We're fighting right there with them. So we want to make sure that people understand that they haven't given up. But now we have a voice. And so collaboratively, we're all coming together and we're putting a voice to this disease. And we're starting to get more awareness that's ever been given before. So they talk about gene therapy now. And gene therapy is a great tool. However, if it isn't accessible, if it isn't affordable, that means that it really isn't a cure, right? And so we have to just put the wisdom to all of the false stereotypes and the social stigmas that's been put out here about sickle cell disease and what it is and what it isn't. And so, yes, there is hope. I'm so excited that our sickle cell warriors, some of them are thriving, but yet they're living with a very chronic, painful disease every single day. But there is absolutely hope. We have not given up.
Thank you, Tabitha. Ginger?
There is no other rare disorder or chronic disorder that experiences the bias, the discrimination, the racism in healthcare that's sickle cell, and it wouldn't be allowed. I don't think that even with the smallest rare disease population, do they see the kind of human atrocities that we see in sickle cell disease. People as soon as they say, I'm here, sickle cell crisis, you can see the provider's face change. Stigmatized just based on the diagnosis without knowing the individual, without doing the basic things, the CDC and all of the other stuff that's supposed to happen when you come in to the ER for care. We've seen people, young adults, thrown out by security who were actually in aplastic crisis. And when they collapsed on the street, had to be rushed back in and now put into ICU because they didn't do what they should have done in the first place, which was do the blood work before you draw any conclusions. People coming in, with double pneumonia and being given a prescription and sent out. These things aren't happening in any other healthcare. But because of the perception of this being an African and African American disease, it seems to be okay to do all of these horrible things. But when we talk about diversity and inclusion, this isn't just an African diaspora disease. The Mediterranean, the Indians, the Southeast Chinese, the Southeast Asians, the Central and Latin Americans, with the exception of the Latin American, I say, everyone else stays away. If everyone else who was affected by sickle cell disease joined with us and stood up, they would absolutely be changing. It would happen a whole lot quicker. But we're doing the fight. They're getting the benefit. Everybody else is getting the benefit from what we're doing, but they won't stand beside us. And, in New York, we don't even know where the Mediterranean and the Asian population with sickle cell and sickle beta thal is. We've been looking for them. We don't see them in the hospitals, inpatient. We don't see them in the clinic. And so when we're talking about diversity and inclusion, we need the others impacted by this disease to stand with us and to advocate, and to the needs that we need to be met. In New York, we've had a bill that's been dead on the floor for 11 going on 12 years, only asking for $8 million for 5 centers. Now I'm going to go, mess up the stuff and ask for 30 million for 15 centers throughout the state, because our community in upstate New York have a right to have basic services. Once you age out of pediatrics, your life is in jeopardy. And it shouldn't be that way in this day and age. We're on a HRSA grant where they're talking about a transition program. And I stopped going to the meeting. I said, transition into what? Why are we wasting our time talking about the needs of transition instead of talking about the needs of adult treatment programs? This is what we need. They were systematically closed, and if we don't watch out, they're going to start closing the pediatric programs too. One hospital tried that in New York, and we rose to the occasion and shut that down because we had to call the board of trustees, right? And so our adults are in jeopardy, but let's not think that our children aren't in jeopardy as well.
Yeah.
And hope is great, but every day we're doing this work, and we do need the help of leadership in government, in the agencies, and also in the health sector and the health industry to support what we're trying to accomplish. We're not asking for a whole lot, and we're not asking for anything that every other disorder isn't already getting. And when you look at the size of our population, we're comparable to HIV, AIDS, and cancer, and we need to be treated as such. And I think basically, I really just wanted to get that across, that our population, for what it is and for its diversity, needs to be considered in the same way that diabetes and HIV/AIDS is considered.
Yeah. Very, very important points. Ginger. And I think, as you said, in speaking about hope, I think there's a hope for many more of us that are actually, unidentified right now. You speak about some of the populations in New York that may have sickle cell, but they're not really, even connected to the community to begin with. So very important. And Linda, I don't think you got to answer that question either, but if you wanted to add anything, because I actually just got wind that we have time for one more question after this, so I'll try and slide that in and be quick, but just wanted to give you a moment to respond.
I just again agree. There has been progress, but not enough. We have been so stigmatized by what sickle cell disease looks like. There is, it's really sad that we are labeled by the disease versus the persons, the amazing, incredible, gifted, never giving up people that just live with sickle cell disease. And I am looking forward to the day where they will see who these great people are and not so much the condition. I want to end by saying this. One of my doctors, she said, if she does not have on her medical coat or her badge, she's considered a drug seeker. She is made to wait because they don't know who she is. But once she says, I'm an MD, I work in pediatrics, then she receives quality care. But quality care should be for everyone. And as I mentioned in my slide, we are going to hold on. We're going to continue to fight until there is a universal cure and we're all treated with dignity and the respect that we deserve.
Mm-hmm.
And if I can, I just want to say, I want to commend Sick Cells, because Sick Cells, the advocacy and all the policy and all that they do, I just have to say to Ashley and her entire team, great job. We appreciate you. We could not do this without you.
From on behalf of the team, thank you for those words. Sick Cells has been at it since 2017, and even probably in some shape or form before that. So we're really just glad to have you all here and be with us and share these sentiments. Ashley actually does need a minute before we wrap up here to close out. So I'm trying to leave her at least 1 minute. But there was one question that did come through in the chat, and it was, how do you collaborate with the healthcare community when you live in a small town? And if there's maybe just one person who wants to give a quick answer to that'd be wonderful. And if not, then I'm sure there can be some follow-up after this. Maybe I'll
help. Because we deal with rural areas already, we have a tendency to create partnerships with federal qualified health centers. So we often refer our sickle cell warriors to the federal qualified health center, but there is absolutely, internet access that will allow you to do Zoom calls with us. You can also do telephone calls with us. You can, contact us through our website, but there are many different resources for an individual living with sickle cell disease that may be in a rural, very small area. So I would say, first reach out, look on. There is a website for SCDAA, Sickle Cell Disease Association of America. She has every single sickle cell organization listed there that is a part of the community. So you could start there and then see which one is in your area, be it Georgia, Texas, Florida, Maryland, so forth and so on. And then again, check with your federal qualified health center, because many community-based organizations have created a relationship there. I hope that answers the question.
Yeah, no, that was wonderful and perfect and within time. So again, thank you all. Ashley, if you are somewhere waiting in the wings, could you please come and close us out?
Great. Well, thank you all so much for participating in the 2024 sickle cell coverage for SCD Summit. This was a very dynamic year. We opened this year hearing from CMMI and understanding that there is real investment, real energy, and real desire to learn from the sickle cell disease community to ensure that there's better quality of care and access to the gene therapies and emerging therapies. We also heard from a state Medicaid and a commercial payer about their strategies to increase access to care. And we heard from community members along the way. We heard from community members, both providers and people living with sickle cell, about just the change that they're seeing in their communities and what increased awareness and access can do for an individual. We also learned from a recipient of gene therapy the lengths that it took to find a gene therapy, even on a clinical trial, and then some of the learnings of what will be required for individuals afterwards. We finished the day with learning about more in detail the funding available through the CGT access model, and then a learning system that is in the works right now, including the community voice, to ensure that we're bringing that voice and elevating it to create solutions. And we closed out our day hearing from the community. So while there's hope and progress, we really want to highlight the urgency to continue this momentum so that individuals with sickle cell can live without stigma and the burden that falls on us to do a lot of this work. So thank you so much for joining us. We'll have this recording available on our website soon, and we look forward to seeing you all next year. And a final thank you to our sponsors for making this possible.